Thank you very much, ladies and gentlemen. I'd like to echo Steph's appreciation for those of you who have struggled through whatever snowdrifts or herds of polar bears or whatever has been in your way to get you here today. Thank you very much for coming. This is the second time I've been with this group as the challenge has progressed. Oh, third time actually, if I count the Celtic and the data dive, and it's been a huge privilege to watch from near or from far as the challenge has progressed, as we are moving along the trajectory that we are celebrating the next stage of today. So thank you very much to Steph and to Data Lab for organising today's event, and it's particularly a pleasure to be at an event which is focused on the dialogue between clinicians, between patients, between companies, members of the public, and all of the stakeholders who care passionately about the effect that the value that data science, e-health and so on can have on very real health challenges for Scotland and indeed for the world. So the Funding Council has been sponsoring this challenge, delighted to do so, and we did it from essentially a motivation to bring innovation centres together to use that vehicle to bring the collaboration of users, in this case the NHS, the scientists and academics in our wonderful universities, and the enabling power of the innovation centres together. Now, we did that because we care passionately about the role that the academic communities in Scotland have for actual, applied, adopted, purposeful change. So not all research is ever going to reach into the real world, if I can be so crude as to put it that way. An awful lot of it can and does, and we believe, therefore, that we should do anything we can to help the universities to make sure that actually does happen. This is an example of the kind of routes that we are trying to enable to give the universities every chance they can to do the wonderful things that they do in an arena of adoption and practice that will make a difference to people's lives. In this case, in an extremely important arena, the arena of cancer treatment and care. So it is particularly pleasing to have so many people from the NHS so deeply and centrally involved in this challenge, because without practical change in the way that patients are treated and cared for, then we're going to get a great deal less out of this. So the involvement of the NHS is extremely important. I'm really pleased with the high-profile role that the IHDP, the Innovative Healthcare Delivery Programme, is having here. I'm very, very pleased that later on, in fact, following this, Hilary Dobson will be speaking about the clinical overview. So involvement of the IHDP, the territorial health boards, and the patients and representatives of the general public is hugely important in ensuring that what we end up with at the output of all of this wonderful work is valuable contributions to Scotland's society through healthcare. So I was delighted, as we've been watching this programme progressing, at the high calibre of applicants, companies that want to work in this space, scientists who want to work with them, universities that are engaged, and delighted that we have three fantastic companies here today on setting off into the next phase of this challenge. We've got a homegrown company. We've got one of the projects that I was delighted to be part of the judging panel with Aileen Keel here. We were looking at the projects in the Data Dive. One of those companies has come through to this stage, and of course another company which has a wealth of experience of working with the NHS. So an excellent balance, working in three different areas of cancer treatment, but with particularly broad and general applicability. So look, I'm between you and the exciting things, so I'll get out of your way, but it's a huge, huge pleasure to welcome you all here this morning. I hope you have a particularly productive day, and that the launch of the next phase of the challenge goes very, very, very livelily. I mean, that's not even an adjective, but I'll use it. Livelily. So I'll hand you back to Steph, and I wish you an extremely productive day. I'll stay for a little while and look forward to hearing something of it. It's been a great pleasure to meet you from this point in front of the stage. Thank you very much.
So I've just got a couple of overview slides of what's going to happen today, so you kind of know what's going on, and then we'll kick off with our first presentation. So, and technology fails me. There we go. So here is the agenda for today, and due to the weather, we're having a wee swap of some of the presentations. So immediately after me, it would have been Dr. Hilary Dobson giving the clinical overview and about the cancer cancer intelligence framework. But unfortunately, she's still stuck on a train from Glasgow, so she'll be running a wee bit late. So Professor David Robertson will actually kick off things with his presentation, Data Science, Big Data, Big Opportunities, Big Challenges. Everyone should have an updated copy of the agenda. There were copies outside, and you'll see that there are tables around here and next door set up for the discussion sessions later. So, just a quick overview of what Phase 1 means. This is us launching the Phase 1 projects. So essentially, each of the companies have 3 months, starting yesterday, to carry out a feasibility study onto the project they proposed. And they have been awarded up to £35,000 each. And they will pitch for Phase 2, which is, and 2 of them will go on to Phase 2, which will see them being awarded £125,000 to take it further for 6 months to develop and evaluate their solution. So the 3 companies, as you can see, you have information about them in the handout at registration, are Canon Medical Research Europe, JX Technology, and Sharp Analytics. Can't see Matt from Sharp. Oh, he's here. Brilliant. All the way from Stockholm. They can deal with snow a lot better than we can. So that's what Phase 1 is. We will have discussion groups later. Everyone will see that there's a coloured spot on your badge. And I'm afraid, Stuart, you don't have one because I think you won't be here. But yes, there's a coloured spot on your badge. And that's just to allocate you into 3 separate groups. So each of the tables, so there's 2 tables over there and there's one next door, will have the coloured spot on them. So please go to that table. We've tried to distribute everyone from different backgrounds evenly across the 3 groups so that the 3 groups have a good representation from all the different backgrounds and perspectives. And essentially, it's an opportunity for the 3 companies to have a more informal dialogue with all of you guys. So the companies will move from table to table instead of everyone moving, because that will be much more difficult logistically. So the companies will move after 30 minutes from each table. So they'll get a chance to speak to all of you. And we will have members of the Cancer Challenges Operations Group on each table to try and prompt discussions if it becomes a tumbleweed moment, which hopefully I won't be. It won't be, because I imagine you'll all have plenty to speak to the companies about. And then refreshments will be served outside the rooms from 3 o'clock onwards throughout the discussion session, so you can just pop out and get something if you need. Comments wall. Yes, you'll see some signs up on the walls, on the doors there, and on the 2 columns. There'll be the kind of comments wall for each of the companies. So there should be Post-its and Sharpies available for you to write comments, feedback, questions, concerns, any thoughts on their projects, and post it on the wall throughout the day. So it's kind of just you've had a thought and you can't hold it till the discussion session. Please write it down and stick it up there, and we'll get the companies to check the wall throughout the day. And they can address any of the things that might not come up in the discussion at the end of the day. Housekeeping, there's currently no fire drills planned, so if there is one, please follow the fire exit signs, and I'm sure the hotel staff will come through and lead us out into wet Edinburgh. And the bathrooms are just outside, and we have lunch later. It'll be a hot lunch, and everyone should have given me specific dietary requirements. So if you had a very specific thing, for example, gluten-free, that should all be ready for you. The plenary sessions will be filmed, so Jakub over there is filming this for us for archive purposes, and if you definitely don't want to be shown in any way whatsoever, please let him know. And we will also be taking photos of the speakers and the general audience for social media and for our records. Yep, and that's it. So I'd like to invite Professor Dave Robertson to come up and talk to us about data. And let me get his presentation.
Okay, I have no idea how long this talk will need to be because it might depend on when Hillary gets her training.
It should be 20 minutes.
Okay, yeah, I'll keep it 20 minutes. That's humane, I suppose. For this particular group, it's a little bit difficult to get the pitch of this talk right. So I thought what I'd do was to say a little bit about the drivers from the data point of view. And then say a little bit about what goes on locally, because I think quite a lot of people think that sort of data and AI and all of that sort of stuff is something that gets done somewhere else.
Could I get you to
yeah, sure.
do this and make it better so that you know how to hold it and you can clip that?
Okay. Okay. Oh yeah, that is better actually. I hardly need to speak at all. It just carries. Something that gets done somewhere else, but quite a lot of this is getting done here. I don't know how many of you actually are part. I come from. I should say I'm Dave Roberts, and I'm from University of Edinburgh. I've been at the University of Edinburgh for a long time. I came in 1985 into what was then the Department of Artificial Intelligence. And I've stayed there ever since, actually, apart from a little sojourn to Barcelona to do my PhD. I'm currently the head of the College of Science and Engineering, but I spent really am a computer scientist, and I've spent quite a bit of time with people in the Usher Institute. So that's what I do. So I thought I'd start off with a little bit about the sort of drivers for medical informatics. So there's a sort of it's almost like a little quiz for you. You know what? Heard of Moore's law? Okay. Capacity of microchips doubles every 2 years. That law is about to kind of run out of steam because we're starting to hit the issues of physics with doing that, but that's a different story. Cooper's law. Have you heard of Cooper's law? Anybody heard of Cooper's law? Transmission capacity for data doubles every 30 months. So loads more data you can push around, loads more processing speed. You're accustomed to these kind of laws. An interesting thing when it's not just the volume of data that's ramping up like this. You can't really read this, but it's the quality of the data. Much more data that's not very strictly curated. In the good old days when I was starting to work, 85 or something like that, you had to curate data very closely. Now most of it you're getting somehow from somebody else. Big issue in healthcare is very little standardization of the data that you're pushing around. And for me as a computer scientist, that means standardization at lots of different levels. Okay. So that's another thing, that's another law, basic law. And that particular law is holding good, I think, for a little while yet, unlike Moore's. Metcalfe's law. Metcalfe's law's good one. Value of a network is proportional to the square of the number of its users. In other words, if you this is actually one I took from Facebook. This is Facebook, the average degrees of separation. How far are you away from somebody else on Facebook? And it's that's actually, I think that's for me actually. It's somewhere about, and I'm very average. So you're about sort of 3 or 4 away from everybody else. Really, you're very, very tightly connected on a lot of these networks. Irum's law. This one I googled that one. I must admit. Cost of developing a new drug roughly doubles every 9 years. That's a bit worrying, actually. So unlike all of the rest that are pushing you forward, this one is pushing you back. Although I put this one up, which is a kind of standard one for many people here will recognize this. This is genomics. And I quite like this one because I love this graph. It's a little bit outdated now, 2007 there. So really, really expensive. That says $100 million. And this is to sequence a genome, a whole genome. So really, really expensive in 2001. And actually this line here is what you predict just from Moore's law, that one. Just wait for the processor speed to speed up and it's going to get cheaper for you. And that's what what would happen if it was just Moore's law that was helping you. So what you're seeing here is Moore's law is doing a bit of the work for you, but it's not taking it down that much. It took it down to 10 million. This is a log scale. So it is helping a lot. And then suddenly, bam, and what's happening is technology is catching up. People are developing the algorithms, they're developing the hardware, and suddenly it's getting to the stage where it's becoming much more plausible to do this at scale. So back to the local theme, sitting here right now, what are we doing in the university? Something like about the capacity is about 15,000 whole genomes, I think, per year. We'll do your genome for 700 quid, and we'll do it in 50 hours. That's the service, approximately. And that's not unique in the world, of course. So that's kind of amazing. This is bad, but there are some amazing shifts in technology. Okay? Last one, well, I called Morris's law, because I work a lot with Andrew Morris. And he's always on at me about being a computer scientist. This is Linux. Linux is a standard operating system for us. This is the Linux Symposium T-shirt size, 1999, medium. We're now getting to be extra large. And actually, there is kind of a serious point to that. It's actually quite difficult to get staff, actually, now here. Training has become a big issue for us. It's a seller's market if you work in data science. At the moment, this will not last forever as everybody gets trained up. For now, that's the case. So a limiting factor in all of this is not just the process speed and so on. It's actually the ability of people with the brains to tackle the problem. And actually, in my personal experience, that typically that isn't just computer scientists, actually. For me, a data scientist isn't necessarily somebody who came up doing computer science and you did all the things that way and never understood the domain. That's probably quite a bad data scientist, actually. Okay, so that's a bit about the drivers. A little bit about the technology base. I'm going to try and go very quickly through this. These slides will be a bit busy. But I'll just gather you through. The main message I want to get across from here is what's going on in the technology base. And this is taken from Edinburgh. If you were to go up the road to informatics, at the end I'll say a little bit about all of the history of that. Because I do intend to do a bit of tub thumping for Edinburgh in amongst this, because I think it is part of what people need to understand. So, technology base, if you were to go up the road and look at what we're doing, it's these kinds of things that we're doing around data and around artificial intelligence. To me, artificial intelligence is just the flip side of data. Good AI typically uses a lot of data in different ways. So we're doing lots of, and this is what used to happen. And this is what's going to happen in future, in the very, very near future. Actually, some of these things are actually pretty much there now. And lots of people, I want to put this in to remind me to say, lots of people who work in AI now will do more than one of these technological things. You look for confluence. You look to trade one technique off against the other. So, very, very quickly, sensors used to be bespoke in the old days. Now they're ubiquitous in network. Robotics, we used to do single components. Now we do full humanoid. If you walk up the road, you can, up in the AI lab at Edinburgh, you'll find a full humanoid robot about my size, moves around and all of that sort of thing. We can do that sort of thing to some reasonable approximation now. Natural language used to be very, very narrow spectrum. Now we're doing it across media. Using things like paired corpus translation to really harness data. Speech recognition used to be all batch stuff. Now we do it real-time, natural, it's on your phone. None of these things are absolutely brilliant. None of these things are exactly as they were advertised in '85 when I started. But a lot of them actually work to some approximation. Machine learning used to be very domain-specific. Now we're commoditizing it. A lot of people in this room will have used machine learning algorithms. They may not be able to build one, but they will know how to use one. So it's becoming commoditized. Data linkage, we used to be single databases. Now multiple semantic web standards matter. Just something I do not believe is understood well enough in healthcare. Data architectures used to be warehousing. Now it's cloud havens. All of those architectures that give you security across distributed databases have become important. Security and also certain kinds of autonomy. Social computation is becoming important. We're starting to do the bit where you use people's brains as part of computation. Not in some evil way, but just to actually be able to help do little bits that computers can't do. People are getting very good at building those kinds of systems. And in security, it used to be a corporate thing. Now it's becoming much more personalized. And actually, there's another story about how AI links into that, because AI is, of course, both a threat and a tool in the security world. So all of these things are now moving very rapidly. They're becoming more mature, and we're looking for confluence. Okay. I want to say a little bit about the research agenda here, and actually some of the there's Steve up there. Where's Steve? He's somewhere. Hello, Steve. So this is one I actually used for a talk about inside the Usher Institute, to which I still belong. There's the Medical Informatics Center, and so I was involved in setting that up. And this is actually a slide I used to explain some of the stuff we do. And I think it's useful here just to see the way that you take some of the things that would be kind of more abstract things from computer science and how you map them onto things more to do with population health and medicine. So here are the kind of main issues in the Center for Medical Informatics. One is ethics and governance. So I don't want to talk about that because there are people here like Steve who really understand that in a way that I never will. Oh, by the way, this is the MRC map of interesting topics, which matters a lot to academics like me because they fund a lot of our research. So actually, and these arrows are showing how we're relevant to this, but you can read as much as that if you want. I'm not going to dwell on that. Quite a lot of probabilistic inference. So probabilistic inference in artificial intelligence is the bit where you represent the uncertainty of information that you possess from your data sets, and you reason about that uncertainty. The important bit in that sentence is about that uncertainty, which is what makes it probabilistic inference. And that's very important for learning health systems, where you want to weigh up different kinds of evidence, aggregate it, and say something about how you expect that system to perform. So there's a huge raft of stuff. It's not used that much in healthcare to tell you something about the properties of these systems. Heterogeneous data, linkage, correlation, all of these sorts of things. People looking at very large data sets in genomics, that's Peter Joshi there. In the extreme case, doing hypothesis-free research, looking for correlations and then trying to see whether those make sense scientifically. Less extreme cases where you have models and you try to confirm. Lots of stuff on networks. Some of them are cellular networks at the level of an individual cell, so you're interested in how those function. Other people like Miguel here, interested in doing things to do with more structural networks. The vascular system behind your eyeball for people who are interested in optical systems. Loads of stuff on machine learning, doing discovery. Loads of stuff on process optimization. For example, optimizing healthcare pathways. A big effort on text analysis and image processing on a large scale. I don't have time to talk about it, but as part of the Safe Haven operation, we're building up a large database of medical images. Steve would be the best person to talk about it because he's really actually holding all of that together. But there's no time to talk about it at the moment, but it exists. And quite a bit of work on federating data, which will be very important. Scotland is great. If you're a computer scientist coming into this area, Scotland is great because you have really quite good access to really quite a lot of data, and a lot of it has been really well maintained, actually. But it's only 5 million folk, and that's not enough for most of the statistical work that you want to do. So at some point, it needs to be federated. And that's not just a technical issue, it's also an organizational issue. So these are the sort of things we're looking at. Okay, so I'm nearly finished. What I wanted to do with the last little bit was just to say a little bit about Edinburgh, actually, because I do think people don't realize this. So standing here right now, then there are two big fashions. One is data science, and the other one is artificial intelligence. And what people tend to forget is actually Edinburgh had the second AI department in the world, at least to my understanding. In 1965, Donald Mickey set it up, actually. Stanford were first. They were in 1963. That was John McCarthy and Marvin Minsky. And of course, when those things were set up, all this is really saying is we had a room with AI people in it 2 years after Stanford had a room with AI people in it. Because that was how it was then, actually. People think of AI as being a new fashion. It really isn't. We've been doing it since '65 in Edinburgh, and we never stopped, actually. I'm actually really proud of this because there was an AI winter between somewhere about the mid-'70s. AI pretty much died out, and it was actually suppressed. If you look on YouTube, do James Lighthill, and you'll see how the physicists actually suppressed AI, because it was not much of a subject at that time. Nobody thought it could ever work, ha-ha. And so it was suppressed. And then, of course, in the 80s, when I started, we had the Albi project. And the reason that was started was because Japan started its fifth-generation computer program, which is to build intelligent computers in the 80s, and the UK government was so terrified that it decided to really fund this stuff. And that was the first wave of AI, actually, in the UK. And then that kind of wave went through and did the usual things that happen. And we're now experiencing yet another wave. And the difference between the wave we're experiencing now and the wave that we experienced about 30 years ago is 30 years ago, we were absolutely certain that none of the stuff that we were doing would actually work. You were pretty much guaranteed, because none of those laws that I was talking about are really fully kicked in. There wasn't enough data, you never had enough knowledge. You could write the algorithms, but you could never really get them to do anything practical. Now it's the other way around. We have loads of commoditized stuff. And the issue is exactly what you can do. It's a more hard-edged subject than it was when we started that. But that's what it's like. That's Hope Park Square, actually, down on the side of the Meadows, which was where all of that started. That's informatics now. Biggest research presence in the UK in computing. Important thing to realize about that building, though, is about 2/3 of it, I would say, is AI research, actually. 6 institutes, 4 of them are AI institutes. Robotics, machine learning, neural, intelligent systems, and who have I forgotten? Oh, natural language and speech. So, right. And we're building that. So if you were to go along there, you see a construction site. September, we opened the Base Center for Data Science. That'll be another 600 people. Informatics about 600. That will be September. I hope you'll visit. And then the aim for the university is to go across the whole university. So there's Base, September. Usher, which will be focused on healthcare and medicine. We hope to build shortly after that. And the marvelous Hogwarts-style Futures Institute shortly after that. When all of this gets going, that would be a couple of thousand people, I suppose. It would be an enormous concentration on the planet of researchers working in this. And then, of course, never forget the data hubs. So there's the ACF, which is actually one of the more boring buildings to look at on the outside. But it's our National Supercomputing Center and also Safe Haven Center. Higgs, doing this in physics, it'll open in about a couple of months' time, actually. So that's another innovation hub, but focused on physics and astronomy. And Easterbush, of course, with genomics. So actually, that's the thought I want to leave you with. So you might think a lot of this stuff gets done somewhere else. But actually, an awful lot of it has been done here and continues to be done here. So that's my upbeat message for you. Is that enough, Steph? Have I entertained folk enough? Or?
Are you entertained? No, that's brilliant. Thank you so much, Dave.
Thank you.
And Hillary's not here yet. However, I've asked Barry, who is meant to be slightly further on, about to speak next, if that's okay.
Yep, this is on okay. Hi, thank you. Yes, I'm Barry Aitken. I'm a research fellow in the medical school at the University of Edinburgh. And as Steph said, I work in the public engagement team of the Farr Institute of Health Informatics Research. So today I wanted to give a bit of an overview of why I consider citizen engagement to be really crucial in relation to data science projects, to give a bit of a background to why there's increasing emphasis on citizen engagement, and then set out some of the reasons why you might do citizen engagement in relation to your data science projects, and then briefly how you might go about doing that. But I should stress, I'm not here to tell you particular methods you should use or to tell you exactly what you should do in relation to data science projects, but more to give an overview of some of the different approaches that people do take to data science and how the different reasons for engaging citizens will shape your decisions around how you might do that. Okay. So to begin with, a bit of background and a bit of context. As we've heard, internationally, there's growing interest in uses of healthcare data, particularly in research, and in data science more generally. So there's increasing public interest and there's increasing media interest in data science, and that's internationally the case. Healthcare data is often considered to be particularly sensitive, and it's an area of particular interest. So there's increasing scrutiny of the ways that healthcare data are used, or how it's collected, how it's shared, how it's used for a variety of purposes. And this has led to increasing interest in citizen engagement and in understanding public attitudes or public issues that lead to public acceptability of uses of data in healthcare research. This is in part in response to previous highly publicised controversies around the ways that healthcare data is used. with a big example being the public controversy around the proposed care.data. And this was several years ago now. There was a very high-profile controversy around the proposed care.data program. And much of this focused on public concerns around the ways that healthcare data would be used and who might access healthcare data, and particularly the involvement of commercial organisations or private companies in potential research uses of healthcare data. But another big reason why this became controversial was also a perceived lack of adequate citizen engagement within the design of care.data. And a sense that public values, public interests, and public concerns weren't adequately addressed in the design of care.data. So there have been important lessons learned from this experience, and it's led to a much greater emphasis on understanding public values, and understanding what it is that concerns members of the public, but also what public preferences are and how we might take those on board in designing data science programs as well as individual projects. And this has led to increasing emphasis on citizen engagement at all stages and in all aspects of data science projects. It's also led to a lot of social science research, which has sought to examine public attitudes towards uses of data in health research and uses of healthcare data. And much of this research has pointed to a similar conclusion, that there is generally widespread public support for uses of healthcare data in research. Generally, the public is very supportive of health research using healthcare data. But that public support is never unconditional. So it's important to think about what are the conditions that need to underpin support, and what is it that we need to attend to ensure that we maintain public support on an ongoing basis. Much of this research suggests that what's really fundamental is a sense that that uses of healthcare data will lead to public benefits. So it's not just about doing clever statistical analysis or creating profits for private companies who might be using that data, but actually it's bringing about public benefits, it's bringing benefits for society or benefits for patient groups. And this is really crucial to ensure and maintain public support for uses of healthcare data. Another key factor is that people need to feel that they can trust the organisations or the individuals who are accessing the data, as well as the individuals and the organisations who are making decisions about how that data is accessed. And this is really fundamental. It requires a focus on what it means for us to be trustworthy and how we ensure trustworthiness in the ways that we are using data and the research practices and governance practices. And again, this points to the importance of citizen engagement, because trust isn't something that you can manufacture. You can't force somebody to trust you, but instead we need to think about how we build up relationships with the public and relationships with citizens to build trust into the practices and into the ways that we're using data in healthcare research. So all of this has pointed to us that they need to really engage much further with members of the public, with citizens, to understand what it is that leads people to support uses of healthcare data and what it is that might lead to public concerns. And it's led to an emphasis on the importance of developing what's called a social license for uses of healthcare data. And this recognises that what is publicly acceptable, or what would be supported by citizens, by members of the public, is not necessarily exactly the same as what is legally permissible. So of course, in all our data science projects, we need to ensure that what we're doing is legally okay, but we also need to make sure that it's socially okay, that it reflects public values and public interests, and that it's going to have the support of members of the public by operating in ways that reflect public preferences and that don't create public concerns. So engaging with citizens is not simply about trying to avoid a negative outcry, trying to avoid a controversy. It's actually a very positive exercise in trying to strengthen data science projects and improve data science projects by ensuring that we're operating with a social license and ensuring that the way that we're using people's data reflects public values and public preferences. So taking a step back more broadly, thinking about why we do citizen engagement in relation to science, and particularly in relation to data science. There are a number of different reasons for engaging members of the public and engaging citizens in data science projects, and these reflect different underpinning rationales. So these different rationales can lead us to take different approaches to citizen engagement and shape how we do it and why we do it. So within the sort of academic literature around citizen engagement, there are three main rationales that are often discussed. And the first of these are normative rationales. So if we're engaging citizens following a normative rationale, we're doing it because simply we consider it to be the right thing to do. So in a democratic society, science should be, as far as possible, inclusive and open, and members of the public have a role to play in shaping scientific practices and scientific processes. So we should engage citizens because it's the right thing to do in a democratic society. Much citizen engagement is actually conducted from more instrumental rationales. So an instrumental rationale views citizen engagement as a means to achieving particular ends. So it perhaps takes a more pragmatic approach where for example, there might be a data science project which is designed and we know what we want to do, but citizen engagement is used as a way of ensuring that there's public support and ensuring that that it has public support. So in that way, citizen engagement can be perhaps a bit more pragmatic, a bit more practical. It's more about enabling something which is already designed and already where there's already an intended outcome. Criticisms of these sorts of approaches to citizen engagement are that they can be quite tokenistic or quite cosmetic. There's very little opportunity for that citizen engagement to actually have an impact or change what happens. So what the value of a citizen engagement is quite questionable. Compared to more substantive rationales, where citizen engagement is seen as being important because it can make things better. So citizen engagement is not so much about enabling a project that is already well worked up and well designed, but actually is a way of thinking about how we can improve those projects and how we can ensure that data science projects are designed and implemented in ways which are informed by public interest and informed by public values. Citizen engagement then can make data science projects better and make data science projects more appropriate, but they can also make things better for citizens and for members of the public. So through enabling those engagement processes, we bring benefits for members of the public to become more involved, to be sort of empowered in relation to the ways that their data is used, and also to have some wider benefits for society, which are perhaps difficult to quantify, but are very important when we're thinking about citizen engagement. So these are three very different perspectives on why we might engage citizens, but I think it's really important to think about that, to know why we're doing it, and then what it is that we should do in response to that. Another important reason for engaging citizens is that we recognise that members of the public have a very wide range of experience, a very wide range of expertise, and that within particular data science teams or even within disciplines, we don't always have access to those wide range of insights and perspectives. So taking on board, engaging with citizens and taking on board those wide range of experiences, the different types of knowledge and the different types of perspectives is an opportunity to learn from those different views and to reflect in a different way on what we're doing to ensure that it takes account of broad public perspectives. So it's an opportunity not just to tell people about what we're doing, but actually to listen to members of the public and to find ways of improving data science projects, as well as improving the outcomes of data science projects and making sure that they're relevant for patients and for the public. So then, how would you engage citizens? Now, as I said, I'm not going to tell you particular methods to use or suggest that there are particular ways that you should be engaging citizens in relation to data science projects. But broadly, there are three main approaches to citizen engagement, which leads to different types of methods being used. Firstly, there's citizen engagement, which is focused at awareness raising. So it's focused at telling people about what we're doing, telling people about the ways that data are used, how they're used in research and the governance processes around that. So about putting information out to the public about data science and data science projects. Then a citizen engagement that's focused at consultation. So finding out how people feel about that, finding out what their preferences are, what their concerns are, finding out if there are particular public interests that we should be addressing in data science projects. And then thirdly, there are approaches that are aimed at empowerment. So aimed at empowering members of the public to have a role in data science projects and to have an influence on the way that data is used or on governance processes. And empowerment can also be perhaps a little bit vague in that we don't always know how people are being empowered, but through being involved in those processes, it can have a very positive effect on citizens and on individuals, as well as on society. Now, of course, these different approaches or different reasons for engaging citizens are not mutually exclusive. So citizen engagement can be aimed at raising awareness of data science projects while also consulting members of the public and hopefully also empowering them in some way. So I think it's really helpful when you're thinking about citizen engagement to think the extent to which you're reflecting each of these different approaches and whether you can be achieving all of these simultaneously through a combination of methods. So the methods that are on this Venn diagram are examples of approaches to citizen engagement which have previously been used in relation to health-related data science projects. But when you're thinking about citizen engagement in relation to particular projects, there's no correct method to use. The decision is much more about it's important to reflect on why you're doing it, what is the purpose of it, and what can change as a result, and then which are the methods which will help you to get to that, to achieve those aims most appropriately. So to summarise, citizen engagement is an opportunity to ensure that data science projects operate with a social license, so that they're operated in ways which, as well as being legally permissible, also reflect public values and public interests, and will be supported by members of the public. Public citizen engagement can be important for maintaining public support for uses of data science, and it's important for ensuring that we have legitimacy for the ways that data are used on an ongoing basis. But it shouldn't be seen as something which is inconvenient, or something which is that we need to do because maybe it's a funding requirement, or because it's about avoiding opposition or controversy, but actually it should be approached in a very positive sense, that this is an opportunity to strengthen data science projects and to improve data science projects through incorporating and addressing new insights and new perspectives which we don't always have access to in our disciplinary teams or in our data science teams. So that's sort of my parting message, that this is a really positive opportunity and a really positive way to improve data science through learning from new insights and new perspectives. So thank you very much.
Let's not over-egg it. I haven't been on the road since 6 o'clock. I don't live in Greenland, but my day started off with a power cut. And as I said to people, what's the worst room that could be affected with a broken bit of kit in a house power cut? Your kitchen. How many appliances have you got? Every cupboard is full. The plugs are all behind. Freezer not working. That was a start to my day. But then I should have just taken the contents out and put it in my back garden, because if you look at the south side of Glasgow, the M77 was gridlock. So nightmare, but I'm here anyway. So I hope this is all worth it. You've been waiting. You've heard the important stuff, actually. You've heard from the patient. Where's Mary? Has she done her talk? Yeah, so that's the real important bit. But really what I was meant to do was to set the scene for you today. So what I want to do in this short presentation, I want to give you some idea of background, context and opportunities that the CIC gives us. And then I want to give you some practical examples. I want to share with you some examples of the challenges that when we face our patients, these are the questions that they're asking us. And if we can unlock the information that's held in digitally held data, this will help us so much. These are some practical examples, and then I'll talk about the key deliverables that we're seeking to achieve. So many of you will have seen these slides, and my boss, Professor Aileen Keel's sitting here. I'm very grateful to her for these slides as well. We know the context about how we want to improve our performance in terms of cancer outcomes. This is looking at cancer mortality in Scotland, and you can see that Scotland is way behind the performance elsewhere. And the big question is that real? How do we explain that? And if it is real, how do we start unpicking the causes for that? Now, the way that the Scottish Government organises cancer services, there is a very strategic approach to this. We have these very aspirational strategies, the cancer plan, and we had one in 2008, it was updated in 2016. And part of the cancer plan mentions this organisation, the Innovative Healthcare Delivery Programme, IHDP. Aileen is the director, I'm her deputy. And these are our high-level aims. A busy slide, but I just want to bring you to this, the last one, that really talks about why we're here today. It's to develop a national cancer data infrastructure for Scotland, linking primary, secondary and ultimately social care data to improve our outcomes for patients. Wouldn't that be great if we could achieve that? And in order to do that, we need to tap into developments and investments from all these areas, working together and collaboratively. And that's what IHDP aims to do. This collaborative approach, garnering all the input from these key stakeholders. And it's actually by having a collaborative approach, we feel that we can crack this nut. Now, it's complicated and there are lots of barriers. If we start mapping the data sets that are there, as Aileen says, we are awash with data, and you can see a very complex slide, which isn't comprehensive. These are not all the data sets. This is just a flavour of the sort of stuff that we're up against. So what we're trying to do is to create a framework whereby we can use technological advances to mine the information from all these data sets in a very seamless and a very timely way, but not only get data out, but create a framework in which the data is discussed in a realistic way with the key stakeholders to say, what does this tell us about our cancer services? And obviously, once we identify some issues, how can we make things better? Both for the services, but more importantly, the outcomes. So there are a number of data sets that we've been working particularly with, and if any of you were at the Collider event, I shared with you some more detail around things like the quality performance indicators, our chemotherapy data sets, our radiotherapy data sets, our primary care data sets, and there are other cancer data. And what we're trying to do is to knit all these together in a way that we can access the data, but also provide a framework to discuss it. So, how's this going to help the coalface? We're doing a clinic today. In the Western General today, there will be lots of clinics ongoing, and doctors will be sitting down and nurses will be sitting down with their patients. And what are the sort of questions that we are being asked? Well, the first thing is, I was a radiologist in my clinical practice. I was very much at the diagnostic end. And the thing that struck me about breaking the news of a cancer diagnosis was it was all about survival. That was the uppermost thing in most people's minds. And these are the sort of questions we'll get. Am I going to be here to see my wee girl go to school? So what we're trying to answer there is we need to have the data to look at the potential survival and mortality. Now, we're pretty good at that already in Scotland. We have a very, very good, robust, credible cancer registration system, and we are pretty good at being able to produce data that will reflect survival and mortality. Another question we're asked, what treatment are you going to give me, doctor? And so, in order to answer that question, we've got a fair armoury at our fingertips of things to offer patients. So we can give them surgery, we can give them radiotherapy, we can give them chemotherapy. But more and more, as we learn more and more about the kinds of cancers, and I'm not talking about is it a breast cancer versus a lung cancer, we are talking about now being able, we're not that far away from being able to do particular tests on the cancers to bring it a much more personal diagnosis. We'll be able to look at special markers that will be able to say, yes, you have breast cancer, but you have this particular type of breast cancer. And that's where we need to look at what we call aggregated data from lots of other people throughout the world who have a similar type of cancer with all these markers that are the same manifestation of that cancer, to be able to make the decision about what's the best treatment for that patient to actually get. Now, there are some tools available, and one in my own area of breast cancer, there is one called Oncotype DX. And what we can do with Oncotype DX is we can then say, right, how much extra benefit, if we were to give this patient who's had her surgery, give her some radiotherapy or give her some chemotherapy, what's the added benefit to that individual patient by the addition of that treatment? So we're now able to put some parameters into a tool which will then run through its algorithm, and it will be able to say, well, if you give this person with that set of markers some chemotherapy, her overall survival will be improved by the order of 1% or 2%. And we as oncologists will know what the side effects are of that treatment. So we'll be able to have a very informed discussion with the patient to say, your added benefit if you go down this line is to have this, and here are the side effects. So it's about a risk versus benefit discussion. Now, if we put the markers in and it came out and said the added benefit was going to be 50%, then obviously that would be a different discussion. Now, we can do that for certain kinds of cancers. We need to be able to do that for more of our cancers to honestly answer that question. The third example, what are my chances of beating this? In other words, what is my prognosis? And in the same way as in breast cancer with Oncotype DX, we do have some tools which work through algorithms to answer that question honestly in terms of if you've this kind of cancer with these kind of markers, here's what we think your prognosis would be, and Predict is a tool that's been developed taking real life cases and mapping out their survival. So wouldn't it be great if we could, again, mine all this digitally held data to offer predictive tools in lots of other cancers? We've tried all the other drugs. Is this one going to work, doctor? In other words, what's the efficacy of non-first line therapies? And again, in my own field of breast cancer, we did some work where we looked at the outputs, the outcomes for patients on their third and fourth line therapies. Now, as a doctor, it's very difficult to say to a patient, we've come to the end of active treatment. There is no other treatment options we can offer you for a curative outcome. Then the conversation has to change into the world of palliation. And again, there's lots of things we can do. But you find that there's always a great temptation to say, let's try this treatment, let's try another treatment, let's try another treatment. And I think we have to have some honest discussions with our patients to say, there are these other things in our armoury we can use, but what are the chances of them being efficacious? What are the chances of them working? And then be saying to the patients, if we're going to extend your life by the order of 2 months, what's your choice about how do you want to spend those 2 months? Do you want to spend it coming up and down to the Beatson and having lots of treatment, or do you want to actually change your focus to more legacy, etc.? So again, we need to mine the data that is held in these data sets to try and work out what is the added benefit of these treatments in order to have an informed discussion with our patients. And I suppose this takes us into the world of realistic medicine. Although a lot of people think that realistic medicine is going to end up with a lot of less, I think you might find some patients will want a bit more. It's not all about less, it's about personalising and having honest conversations with patients about what they want. Example 5. Is the unit I'm attending, and more we're being asked about it, is it geared up to deliver the best treatment? You as a doctor, are you a specialist? Very often we get asked that question now. People are much more informed about the fact that there are standards of care. And in other words, what's the evidence of benchmarking individual surgeons, individual practitioners, or individual units? And a lot of work was done in the quality performance indicators, which I talked about a lot at the Collider event. But again, just to briefly remind you, what is a QPI? It is an actual or proxy measure of quality of care, but the key things about them, they have to be evidence-based, they have to be outcome-focused, and they have to clearly be measurable. And the idea is to create a system where everybody measures their performance against that target, and we want to try and use the information about performance there to drive up standards of care. We have got a set of QPIs for each of our tumours. There are 10 to 14 standards for each tumour, and we've been very prescribed about the way we will define and measure these and how we present the data. And the front end of this is in a dashboard format whereby the clinicians get fed back this, and they use these dashboards to have discussions on a national basis, but you can actually take it to your own MDT and you can toggle between national, regional, board and your individual unit to see where you are in the pecking order. So for example, this is the dashboard for, again, breast cancer, and we're using the QPI, which is about preoperative assessment of the armpit to see if the nodes are involved. And you can quickly see if the target is here, you can quickly run your eye along and see which health boards are actually meeting the target, which ones are a bit more challenged. And you can actually toggle down to see your own performance as a unit. And we don't at the moment present it surgeon by surgeon, because certainly in the world of breast cancer, it's a team game here. So, again, I went into more detail about this at the Collider event, but if you imagine that you are diagnosed today with breast cancer, you're effectively on a 10-month treatment pathway till you finish your first treatment. So if we look at a calendar year or a cohort of patients who are measured, who are being diagnosed in a calendar year between the 1st of December and the 1st of January and 31st of December, the treatment for that last lady coming into this cohort on the 31st of December will be completed by October the following year. It takes 6 months to complete the data collection, which is done manually, by going into digitally held portals and so on, extracting data items, putting it into a spreadsheet, and then creating another spreadsheet to report on it. So we then produce the first data report in about July of the following year. We allow the units to actually have a look at it to see, fill in the gaps, make sure it's accurate. We rerun the clean data. Then each board has to develop its action plan. We then sit in a room and have a chat about it on a national basis. So taking account of a 10-month treatment pathway, so a woman who's diagnosed in December, who we have to make sure that she is included in this cohort of people. If you're diagnosed between December, in the calendar year 2014, we sat down in January of last year to talk about it. Now that's great that we've actually got data and we're talking about it, but it's not really timely because we're looking at data that's at least 2 years old. So for those standards where perhaps some units are being challenged, then the individuals from that unit who are being asked, why are you not meeting that? What can we do to help you? They say, we do things differently now because it's 2-year-old data. We need to access the data in a much more timely way. Another question we get asked, see that radiotherapy doctor I got 5 years ago and I've now got a problem with my bone. Was that caused by my radiotherapy? In other words, we're looking at side effects early and late, more importantly, late side effects. And so again, we need to have the data to be able to correlate these effects going back to the original treatments that they got. If it was radiotherapy, what kinds of radiotherapy, what was the sequence, etc. And another one, has the treatment worked for my cancer? In other words, we're wanting to monitor response to treatment. Now, sometimes that's pretty straightforward. We can do a blood test. If it's ovarian cancer, we can look for a tumour marker which circulates in the blood. A quick blood test, we'll be able to say, yes, there's no evidence that your cancer's active. But an awful lot of monitoring the response to treatment is based on imaging, my own specialty, and that is hugely subjective. And if we could get some tools that could objectify how we actually look at images and monitor response to treatment, that would be magnificent, because it's great to be able to relay back to the patient, but also it will inform our decision about whether or not we should be changing the treatment options there. Another area where more recently this became a practical issue is we're developing QPIs we're reviewing the QPIs for brain cancer, and we're putting in a new key QPI, which is to actually say to the surgeons, you need to have to remove 90% of that tumour. How do we do that? If you get 10 neuroradiologists in a room looking at head CT scans or head MRIs, they'll all give a different response because it's hugely subjective. So we need to tap into tools to see if we can try and objectify that as well. Huge challenges. These are large, complex, heterogeneous data sets. We've got different versions sometimes of what we set out to make a national system, but the way it's been rolled out, we've got different versions. And I would show you an example of our chemotherapy set up. Many years ago, the government said there should be electronic prescribing for chemotherapy, but actually, although it was centrally funded in Scotland and was rolled out over a period of 2 to 3 years, we have 5 different versions of the same system. So how do we tap into that to do some national reporting? And in fact, our colleagues in NSS have now derived a solution. We've done a proof of concept and they've derived a new technological solution that is able to reconcile asking one question of 5 systems of the same type of system. A lot of this information is held in legacy systems. Very worryingly, but not at all surprisingly, I was one of them, you will get local databases because local clinicians create their local spreadsheets because they don't get the answers from the actual NHS systems. So a lot of this gold mine of information is all sitting on these local databases. And a lot of the information is in a non-codified form. So we've got it in text, and as I say, we've got it in imaging information. So that's a challenge to us. How can we also integrate new tools? I talked about the fact there are some prognostic tools out there. How do we actually integrate these into our NHS work? And as I say, I would love to have an objective way to monitoring response to treatment. So my last slide really is about what the key deliverables of the innovative challenge is. We want to have a modern and innovative approach to data integration where silos of data are integrated without moving them and without duplicating entry of data. That would be fantastic. We want the solution from the CIC to add real value. There is no point in people who are technological experts creating a solution out there that is not meaningful to our clinical colleagues and our patients. It's got to add real value to what we do. And the solution clearly has got to be compatible with NHS Scotland's systems and therefore has to be scalable as well. Not just compatible, but scalable. And the solution must be found within the current system of information governance. And that's a whole new day. So what I've put, hopefully, you should have had this at the top of the meeting, was the background and the context and the opportunities that we have with the CIC. I've given you some real-life examples of day-to-day life sitting in a clinic with patients in front of us, and also summarise the key deliverables we seek from working with you. Thanks for your attention.
Hello, everybody. Welcome back from your coffee. My name's Andy Mount. I'm chair of the Cancer Innovation Challenge Strategic Management Board, and I see some of my colleagues around who've been assisting me in assessing these phase 1 and phase 2 projects. So first of all, can I say it's a great time to be here. We've done a lot of hard work, and you companies have actually made it hard work for us by putting in such really good proposals. And certainly what we've reflected on is how much the first set, the phase 1 programs, how much was done with so little. So we're expecting you guys to do great things in these phase 1 and feed into make our lives tough when it comes to the phase 2 decision making. Anyway, the main part of what we're about to do now is to hear presentations from the companies. I think they started yesterday, so I'm not expecting too much other than what you want to do, but as a way to stimulate some thinking in the room. After we've done that and gone around the 3 companies, we'll then have some reflections from the previous speakers, and all of this is to inform you to think of questions in the roundtable session that you might like to talk to the companies about and give input and get feedback about these 3 company presentations. So without further ado, can I pass over to what in the original programme was called Company 1 and is now, I know, Canon, who will talk about their programme, the phase 1 programme. Okay? Thanks very much.
Good morning. Is that working? Can you hear that? Yeah. Okay. So it's a pleasure to talk to you about our introduce our project. So my name's Kevin Blythe. I'm a chest physician by trade, so I'm not a Canon employee. We're going to do a bit of a tag team presentation. I'm going to give you some introduction to the disease area that we're planning to study and some of the challenges we hope to tackle. And then Keith, who's my colleague from Canon, is going to come and talk a little bit more about the AI deep learning elements of the study. So our project is entitled Automatic RECIST Measurement in Mesothelioma by Deep Learning. And RECIST measurement is essentially a score that's allocated by radiologists to determine whether a patient is responding on their imaging to a cancer treatment. And Hilary touched on some of the issues around RECIST, and I'll maybe mention those again as we work through. So this is a collaborative project between ourself, which is the NHS Greater Glasgow and Clyde, and particularly the Glasgow Pleural Disease Unit where I work. We have a translational research programme focused on mesothelioma, and I'll talk to you about that, and obviously Canon. So the team really is myself. We're supported by Roma Armstrong, who many of you will know, who's our senior R&D manager in Glasgow, and 2 consultant radiologists. And then we've got the Canon team. Keith is going to talk to us a little bit about the technical aspects. We've got Vismantas, Erin and Dominic, who are all here as well. Now, just a bit of context. So this, I just want you to get your head around the problem. So this is a normal right lung. Okay, these pictures are actually prepared by a surgeon in mesothelioma in the States. They're beautiful drawings. He's got a whole range of them, but they're great for teaching. So this is a normal right lung. This is the chest wall here, and this is the diaphragm muscle. And the purple space in between is called the pleural space, which is really a potential space in health that just has a tiny amount of fluid that lubricates the lung as we breathe. Mesothelioma is a cancer that develops in the pleural space. So it's not a lung cancer, and that's quite important. It's a disease of the pleura, and it covers the inside of the rib cage, the outside of the lung, the diaphragm, and it can eventually invade into these structures and is a very difficult cancer to treat. It's also a very difficult cancer to image, which is part of the reason we've chosen it. Now, you may have heard of mesothelioma, and the reason you've probably heard of it is because it's very closely related to asbestos exposure. Unusually, there's a latent period of 30, 40, 50 years between when an ex-asbestos worker usually is exposed to asbestos fibres and then develops this cancer. It's currently incurable, and the average patient will live about a year, although there's quite a bit of variation around that. And the incidence in the UK is extremely high. It's still a rare cancer, but we currently are experiencing the highest incidence on the planet. And if you look at the incidence of meso across the UK, in the dark blue you'll see hotspots. And if you think about the thing that connects these places, then the thing that connects them is shipbuilding or a legacy of heavy industry. And so Glasgow, actually West Dunbartonshire, has the highest incidence of mesothelioma in the UK, and therefore the highest incidence at the moment on the planet. So it's a big problem for us. This is an image taken from a mosquito in 1940, and this image explains why I see so much mesothelioma where I work. So I worked in the Queen Elizabeth, which used to be called the Southern General, and then you have 3 shipyards within a mile of that hospital. So we have a big problem to deal with. There is a perception that mesothelioma is going to go away because asbestos was banned in the UK in the 90s, 80s, but unfortunately that's not the case. These are images taken from Google in the last year that show children, young adults in heavily populated countries like Brazil, India, Russia, where there is no asbestos control at all. And so the global meso epidemic has not actually started yet. So what we learn here will be valuable across the globe. Now, we have various problems in meso. One of the most difficult problems is actually deciding who should get treatment and who should go into a clinical trial. And the only licensed treatment for meso at the moment is chemotherapy. But unfortunately, the chemotherapy drugs only work in about 1/3 of the patients we give it to, and they have significant toxicity. And that affects, obviously, treatment rates, but it also affects clinical trial rates, because every trial of a new drug is comparing a new drug with chemo. And so patients are reluctant for various reasons to go into trials where there is this uncertainty. So a problem that we are trying to address is around a predictive biomarker for chemo response. And this study, PRISM, is the study that we're going to leverage to allow us to look at automated RECIST with an AI approach. And so I'm just going to touch briefly on this study just so, again, you get that context. So PRISM is a study that I'm running, which was generously funded by the British Lung Foundation. And just briefly, we're looking essentially for a genomic signature, a signature in the tumour genes that predict a response to chemotherapy or not. And we have these various partners, including a biotech company in Edinburgh who are doing our bioinformatic analysis. Just the hypothesis in PRISM is that chemoresistance is causally related to genomic instability and high copy number aberrations, and that's just a genomic feature which we're looking at, and we hope to be able to stratify patients to chemo or not, and into maybe a first-line trial that doesn't involve chemo. And in terms of our objectives, what we aim to do is to look at a test set and a validation cohort, actually 2 validation cohorts. So just very briefly, we are extracting DNA from 220 tumours from Glasgow and Leicester. We're doing a genomic analysis, and then we're developing a signature. But this is the bit that matters for this project. RECIST, as I'll come on to in a couple of slides just to mention, has got issues around inter-observer variation. One radiologist will give you a different number to a different radiologist. And so in PRISM, because our signature is so critical, we've chosen to re-report all our CT scans in triplicate. So we're going to have as robust a response measurement as you could possibly get, more robust than you would get if you just pulled scans from the NHS archive. And then we'll go on and validate any signature in 2 external validation cohorts from a bank of meso tissue and a clinical trial of meso. This is the problem that Hilary mentioned, and it's the reason that we are re-reporting all our CT scans in triplicate, and we're going to use that data in our CIC project. This is taken from a paper where 6 radiologists were asked to make a measurement of an area of pleural tumour from a starting point in red, and they did that blinded and independent of each other, and they all made a slightly different measurement. What a radiologist is required to do with modified RECIST and mesothelioma is that they're required to make 6 measurements. So they look at the CT scan, they then use their digital calipers to draw a line perpendicular to the chest wall, and then they do that at 3 slices and two caliper measurements at each of those 3 slices. And then you get a sum of those measurements, and that sum of measurements relative to the previous CT scan will tell you whether the patient's responding, progressing, or they're stable. But the issue is, as we've mentioned, is that there's enormous, well, considerable variation between radiologists. And the radiologist is beholden to the measurements that were taken on the previous scan. Previous papers would suggest up to 30% variation between readers. What that means is that for patients, for meso patients, they cannot get into a clinical trial if they have small, bulky disease, small disease. If your disease is less than a centimetre, it's felt to be too small to be reliably measured. So we're then having to wait to get patients onto treatment. It's also quite time consuming. It's not always used in routine NHS care. And it also increases expense and risk in clinical trials of new drugs, where you have to have multiple reporters. So what we are aiming to do is, this is kind of a slightly complex slide, but it's just to illustrate the various governance issues around data that we've touched on in some of the talks, and the various approvals that we need to go through in our project to allow data to be released to Canon to be deployed in their AI algorithm. What we intend to do is we're having all our scans de-identified by various means, and then via a safe haven ethics and R&D approval and a data sharing agreement, we'll be able to release that data out to Canon to deploy their AI systems. And I'll hand over to Keith just so he can talk about the mechanics. I think my final point would be just to make that this is quite a difficult test case. Meso is quite a complex tumour, but if we can make this work in mesothelioma, this sort of automated RECIST could essentially be deployed in other cancers. This is not an only meso solution. This could have a broad application. So I'll hand over to Keith.
Brilliant, thanks very much, Kevin, and good morning, everybody. Press the right button, there we go. As Kevin said, my name's Keith Goatman, and I'm Principal Scientist in the AI research team at Canon Medical in Edinburgh. And Canon Medical may not be a familiar name to you, even if you work in the NHS, and that's because, as a medical company, it's relatively new. Canon, in fact, bought Toshiba Medical Systems around about a year ago, and on the 4th of January this year, changed the brand name to Canon Medical. So we're a very young company, but Toshiba Medical is over 100 years old. So we also have a very long tradition of working in this area. And we're one of the largest manufacturers in the world of medical imaging equipment. So CT, MR, nuclear medicine, ultrasound. We produce scanners in all of those markets. And I was very interested in Dave's talk where he mentioned all the growth of AI in Edinburgh and Edinburgh's history in AI. Canon Medical too believe in Edinburgh for AI, and they've recently announced that they want us here in Edinburgh to be their global centre of excellence in AI research, which we're really pleased about. And it's within this centre of excellence that this project will take place. So just to reiterate what Kevin's already said about the problem, what we want is a quantitative measurement of tumour response to know how well it responds to treatment. And this is important for precision medicine and for treatment evaluation. Precision medicine is for the individual. What's the best way that I can treat this patient? What's the best treatment for me? That allows us to answer that question. And treatment evaluation is more of a population-based thing. Given a particular drug, how well does it perform? What's the efficacy of it? And if we have a good, precise measurement of tumour response, it allows us to do these two things better. And so we've got modified RECIST at the moment. It's the measure of choice. But as we saw in the earlier slides, its repeatability is poor. That means the precision of it is poor. But it's also time-consuming. An important point on one of Kevin's earlier slides was it's considered too time-consuming for routine care. And what we want is something that will be useful for studies, but can also help in routine care as well. And our proposed solution, funnily enough, is to automate it, is to get a machine to do that tedious task well for us. And we'd like to use a machine learning solution, and in particular one that's based on deep learning. Now, I don't know how many people in the audience are familiar with machine learning, so apologies if this is old hat to you. But the foundation of machine learning is that the machine learns to do a task from a set of data. So traditionally, we tended to look at a problem and find a model for it and then get a machine to do that model. In machine learning, you set the machine up, you give it lots and lots of example data sets and tell it what the answer for those data sets is, and the machine learns to do that task itself. It's a very, very powerful technique. And it means that you have a two-stage approach to the problem. You have a training stage where you teach the machine to do the task, and then we use the thing in practice, or we test it. So why deep learning? There's lots and lots of types of machine learning. What does deep learning give us? And the answer at the bottom there is because it just works so well. I've been working in medical imaging for over 20 years now, and I've seen lots of techniques come along which became possible because the computing power increased, Moore's law and so forth, allowed them to happen. But in all that time, I haven't seen anything as dominant as deep learning. Deep learning is applicable across such a wide range of techniques. It really is taking over. But it started around about 2012. It was a challenge, quite a technical challenge. Can computers detect objects in images? And it was something called the ImageNet challenge. And there was all these images that were just scraped off the internet. And then they were crowdsourced labeled. So people looked at these images and said, was it a cat, a dog, and so forth. And in fact, they had 1,000 different object categories and 1.2 million training images and 100,000 test images. And if you look at the results back in 2010, when it was first done, just over 1 in 4 was misclassified by the computer. And that's still really good, that it's getting almost 3 out of 4 correct. But then in 2012, you can see there was this great big improvement in performance. And that was when deep learning came along. That's when it was applied for the first time in anger, and there was a 10% drop in the error rate. And since that date, you can see it's gone on improving all the time until here in 2015, we get to an interesting point on the graph where we've gone below this dashed line here, which is where they consider human error to be. So we're saying that from 2015 onwards, the computer was doing better in this task than humans were. And that's quite interesting. It created a few scare stories about computers taking over the world, computers replacing people. Do we need doctors anymore? And I think what's important to remember is that this is a very specific task that you've asked a computer to do. Computers are very good at certain things. So, for instance, a computer wouldn't blink an eyelid if it had eyelids at doing 1 million square roots a second, whereas clearly I can't possibly do that. But reasoning tasks and things, people are much better at. And so I think the important thing to do is that we exploit what computers are good at. And as AI improves and continues, we find more and more things that computers are actually very good at. So they're very good at making accurate and repeatable measures like we want to do in this project. And so what we want to do is to exploit what computers are good at to aid clinicians in doing what they're good at. And I think that's the bottom line of this project.
Okay, thank you very much.
And my name is Mel Brola. I'm from JX Technology. We have been successful in this competition, phase 1, which we are really excited about. JX Technology is a company that's been working with the NHS for over 30 years. And we specialize in patient workflow solutions and optimizing patient workflows for primary and secondary care, as well as driving efficiencies through technology. To date, we integrated with with pretty much all of the GP systems, and also with majority of the EPR systems used in hospitals across UK. We've got about 80% of the UK market for GP practices, and we work with over 40 NHS trusts across all of UK, including obviously Scotland, Wales, and Northern Ireland. So we will be in this competition. We obviously looked into the current problems around data in the cancer care, and very much of what Hilary mentioned in her presentation, that Scotland has got a very good and strong cancer registry data, which spans for over 50 years of data from sort of 1960s, 1950s. The cancer registry collects comprehensive data that is being used for sort of nationwide statistics and surveillance. But there are some gaps in how the data is collected or how fast the data can get into the registry, as Hilary mentioned. So we will be looking at helping with these aspects of potential limitations for the clinicians to be able to access the data and actually drive the insights from the data on an ad hoc basis and in real time. There's also issues with the sheer amount of data and the way it's being collected on the national level. As Hilary mentioned, it very often becomes outdated by the time it can be used to drive insights and improvements. Also, there is a lot of disparate sources of cancer data in all of UK and also in Scotland. And it is a very extensive and diverse disease area, and obviously there's loads of systems where the cancer data is being held. And also, it's not only the issue of accessing all those systems and driving the data through it, but then also adding new data like genomics and new markers which are being discovered and developed. So we looked at one of those areas, which is hematology data, and currently there is some shortage of that data in the Scottish Cancer Registry. So we partnered with clinicians from NHS Lothian that currently use their own hematology database, where they record all the diagnostics and diagnosis for hematology cancers and other rare hematology conditions that they treat on a daily basis. So we will be working with them to help them to bring that old database, which is over 30 years old, and it sits on one of the computers in the clinical rooms and can be accessed only by one or two clinicians. We will be helping to drive this data to move this data onto a new modern platform that can link with other data, including cancer registry, to complement it, and also to help them to drive insights from this data that will help them in prevention and also in better treatment of the hematology cancers. So this hopefully will be our end game in terms of what we are trying to achieve through our project is to build a clinical access platform that will help with bringing all the dispersed data together. So we will be looking at the data from the cancer registry, data from the third-party systems like EPR, clinical data, genomics, also the sort of database, individual databases and other data sources that we identified or will identify through the feasibility study. And we also will be looking at potentially, or we will be engaging with patients, because there is a number of stakeholders in this game. There are obviously clinicians and researchers and clinical researchers. There are policymakers and the sort of general governance and people who make the strategic decisions about where the healthcare and where the cancer prevention and treatment should go and how it should be approached. But there is also a group of patients involved in the process, and we want to focus on the engagement of the patients through patient-reported outcome measures and patient feedback, and they can also input the data into the platform, into the framework, whereby we can look at monitoring things such as quality of life, and how actually specific treatments to specific cancers affect the patient's quality of survival. So the system, we will be looking at real-world evidence and evidence-based registries, and the framework that hopefully will allow all these dispersed data to be brought together into the platform, which can complement the existing systems, but allow stakeholders for the real-time access to the data. Obviously, we will be looking at all the data governance and making sure that people get only access to the data that they are allowed to access, and it's done in an ethical and secure way. And there will be a lot of scientific or sort of data science going on in this part of the diagram, where we will be using some of the existing components of the info frame and framed it through our partners Pulse info frame to make sure that we are not reinventing the wheel, and we are not spending time on dealing with all the sort of data security and the frame and the build of the actual registry. We will be bringing those components together to make sure that we can focus on actually the integration of the data, and also designing this side, which will be the what stakeholders want to get out of the system. So obviously all the data will feed in the system. They will feed through the registry. They will also use correlation and machine science to curate the data and to map data to the international standards, so that the data can actually be analyzed and they can be used for research or for the sort of regulatory and policy making, as well as speed up the recruitment from the clinical trials and encourage and enable clinical collaboration to drive innovation and to get better outcomes for the treatment of the conditions. We will be starting with the hematology cancers, but this solution will be scalable and accessible through, we are hoping to have it a cloud-based, so it's easy to access. Obviously, it will be a secured access for stakeholders, and we will be starting from hematology cancers, but it will be a scalable solution. So we are hoping to be able to expand it onto all other cancers with time. So in terms of the approach for the feasibility study for the phase 1, as I said, we will be working with a local hematology database. So we will be analyzing the existing data that is being held in that database, and we will be also analyzing the existing data links. So what systems we should integrate with to automate the data entry, and also to make sure that data is not being duplicated, but it complements the existing systems and it works in sync with the current infrastructure. We will be then, based on the existing data, based on the data links, and also based on what the clinicians want to do with the data and how they want to use it to improve the outcomes for their patients, and to be able to answer all these questions that Hilary mentioned patients are asking when they are diagnosed with cancer, to be able to answer them based on real-world evidence and based on the actual data, strong data that supports it. We will be planning new data structure for the existing database, and we will be planning the interface with other systems, and then we will be also planning and building the user interface for the clinicians that will actually focus on user experience and making sure that it's easy for clinicians to use it, because the clinicians don't have time to operate multiple systems or operate system that does not work in sync with their workflow, with the clinical workflows. So we will be working with the clinicians from NHS Lothian and actually hoping to, during the phase 1, we are hoping to actually look at sort of engaging wider stakeholder group to design as a comprehensive system as possible. And we will be also analyzing reporting requirements and making sure that our system analytics can support all the requirements that clinicians may have. And that's pretty much it in terms of a short summary of what we are trying to achieve.
So, firstly, hi. I'm Matt. I'm here representing Sharp Analytics. Just a little background on Sharp Analytics, the company. We're new, very new, in fact. So about 9 months ago, I think it was, just underneath the castle, there was the Cancer Challenge data dive. And I stood up and I said, hi, I'm Matt, I'm a data scientist, I work for Skyscanner, and I'm looking to build something cool. And the guy next to me, he was like, oh, I'm Ian, I'm a doctor with the NHS. I'm looking to build something cool too. We should do that. And that's kind of how this got started. And it's just sort of gone, and here we are. So, yeah, also, that's no longer the case. I now live in Sweden, working for Spotify as a senior data scientist. Oddly enough, I think my commute here was easier than other people's commute here, which is, yeah, I don't know how that works, but there you have it. So, our project, using machine learning to estimate outcomes in Scottish cancer patients. So how long do I have left to live? What choices should I make? It's a horrible question. It's a horrible question to have to ask. It's a horrible question to have to answer. But thousands of people have to ask and answer that question every day. So that's what we're looking at. It's a big thing. We're aiming big with this one. So who's this an interesting question for, and why is it interesting to them? So we've got patients, obviously. If you don't have long left to live, you want to know how long you've got left to live. Bucket lists. I'm sure we're all aware of bucket lists. Like, do I have time to go to that wedding? Should I cancel my holiday? Like, these sorts of things. These are really important things. These are important things that you're trying to work out. Families. Do I need to quit my job and move across the country? Do I need to start saving for funeral expenses? Should I pull the kids out of school? Like, these sorts of things. And doctors, they've got to answer this question. Not only have they got to come up with an answer to this question, they've also, it informs treatment decisions. It informs what treatments they offer to the patients. It informs how they talk to their patients. So I hope you're convinced. It's a really important question to try and answer. Is it easy to answer? Well, no, not really. It's actually really difficult to answer. So this is a slew of papers and headlines and various other things talking about just how difficult it is. So there are a few points I want to dig in on this slide here. So there's, in that bottom right-hand corner, there's a British Medical Journal paper. It's from a while ago, and it's for hospice patients. And it was effectively, it was a measure. It said, okay, we've got some patients here. Can we predict how long they are going to live for in this situation? Looking at the results I was expecting, I don't know, 10% out, 20% out, maybe 30% out. At 50% out, I was thinking, oh, that would be very far out. The actual results on this, over 500% out. So in this particular study, when a doctor said you have 10 months left to live, On average, you had about 2 months left to live, or something along those lines. There's a little snippet from one of the papers in the bottom right-hand corner here. I think it is absurd that bureaucrats demand we do something, i.e. estimate prognosis, that cannot be done with the current state of knowledge. So, just coming back to this slide here, I think it's unfair at the moment. It's unfair for patients, it's unfair for families, and it's unfair for doctors that they have to try and do this at the moment without as much support as we can possibly give them. Okay, that's where hopefully we come in. Sharp Analytics, our project using machine learning to estimate outcomes in Scottish cancer patients. Okay, so this is a 50,000 feet view of our project and all of the various things that we are going to try and do in the next 3 months. Ambitious. Again, I can't stress this enough, ambitious. What I'm going to do is quickly skip past this slide, but feel free to ask us anything about any of these things and feedback on these things later on. This, as a data scientist, this is my favourite bit, the data. So, the data that we're hoping to use, SMR01, this is the general acute inpatient and day case. So when people get admitted to a hospital in Scotland, how often, when, and for what, and how long are they in hospital? That's what this data is. So there's the generic data. This is general patient data. This is your age, your height, these sorts of things. And then the cancer registry. So 55,000 cases every single year. This is all of the incidents of cancer in Scotland. That's kind of what we're starting with. Now, I've categorised them here. You may have your own categorisations, and that's fine. They're obviously interesting. If you're trying to predict how long somebody in the later stages of cancer has got left to live, things that you're really going to want to be looking at: the age, the gender, date of cancer discovery, the type of cancer, tumour size, clinical extent of disease, and ultimately the date of death. Those things, I don't think we'd disagree. They're probably going to be important in looking at this model. You've got the probably interesting. So what treatments have already been carried out? Specific cancer features, features that are actually specific to that cancer type. Socioeconomic data. This is an interesting one. So, or at least I think it's an interesting one. There's been, I believe, a lot of studies on this that basically say that socioeconomic data is important in treatment and in things like that. It's probably a fair bet that it's important in calculating prognosis. Number of inpatient visits and length of inpatient stay. So these are all coming from SMR01. Like, are you in and out of hospital a lot? Are you not? How long are you in there for? I think it's a fairly safe bet that they will be important. And then you've got these ones, which I call them maybe interesting, but I find really, really interesting. And so these are the, I wonder, like, do these actually have an impact? Do these have an effect? So how typical has the patient's treatment path been through the system? Have they followed a fairly standard path, or has it been different? The day of week of initial diagnosis. So this one, yeah, there's, I don't know, certainly discussion in the data community around the idea that people who come in on a Sunday tend to live for not as long and these sorts of things. Is that an interesting feature or is it not? Well, we're hoping to find out. Previous incidences of cancer. If you had cancer 30 years ago, recovered, does that have an impact? I would say who knows. I'm sure somebody in this room probably does know, but then we're also hoping to find out. And then previous illnesses and additional, like, concurrent illnesses. If you've got the flu, does that make an impact? Does that change things? So these are the things we're hoping to look into from the data. As I say, I like this slide. So the process. Now, this is the data science process. This is the process that I tend to use. I've used it for work and at various other times. So these are all the stages. Now, I'm not going to run through all of them, but I guess I'll just talk briefly about some of them. If it looks like I'm going to run through all of them, tell me to stop. So we've got data exploration. This is really understanding the data, working out what is there. Are there inconsistencies? Are there problems in any of the data fields? And then, like, what's the range of these data? So as a non-medical specialist, I don't know a lot of these things. Like, if I see a Gleason major score, I don't know what that is. So this is an understanding part. Munging and normalizing. This is making sure everything's right, everything lines up, everything is as you expect it to be. And then feature generation. So when I was talking about things like inpatient, we don't have the number of inpatient visits that the patient had in the last 3 days. That doesn't exist anywhere in our data set. That's what we'd call a calculated field. So we can calculate all of these things that we think might be interesting to feed into the model. Model selection, what's the best model for the job? There's a no free lunch hypothesis, which basically says that there is no one machine learning technique that is the right technique for every single problem. It'd be lovely if there was, because then you just use that, although it would then put people like me out of a job. Yeah, this is all fine. This one, number 8, explaining the model. Does it pass the sense check? So this is one, and this is where we're working with doctors to really get a view of this. I'm not a domain expert in cancer. So, I suppose as a simple example, if we build this model and it says that the 2 most important features to estimate how long you've got left to live are your height and your eye colour, that's probably not true. Now, I know that's not true, but there's a whole bunch of other things it could say. It needs to pass the sense check, the doctor check of, well, is this reasonable? Does this actually make sense? Could this be true? And then saving the pipeline and model so we can use it later. Okay, so the output. Now, again, this is all subject to feedback. We are going to work with doctors, we're going to work with patients, just to try and understand what the doctor needs to be able to see to have this conversation with their patient. But this is a quick prototype. It's effectively life expectancy, and then not only are we giving kind of a number, which is wherever this lines up, but we're also giving an indication of how uncertain we are. So it's clear that we're not saying this is the number, this is definitely the number, and that's the case. We're saying, look, probably no more than 90 days, probably no less than 30 days. Okay, this is, to be honest, where I was probably going to leave it, to be addressed. So these are things that we're trying to answer right now that we've started. There's a lot of questions there. There's some difficult questions, and there are things that we're working through. If you can help us answer any of these questions, that would be absolutely brilliant and much appreciated. And I think that's everything. Thank you.
Okay, thanks very much. So, that's been a quick whistle-stop tour through the 3 programmes. I guess we move on to the next stage, which is some feedback, first of all, from our expert panel. And you know 3 of them already, Mari, Hilary and Dave. We're adding to that panel Steve, Pavis and Tammy Watchorn. So I guess there are 5 chairs up here. I guess the idea is that the 5 people come up and sit here. Is that right,
Yes,
Steph?
please. Yes, please.
So that then you can be, all your wonderful words can be recorded for future benefit. Okay? Where we see opportunities, issues to be dealt with for Canon. Who would like to start from the panel?
I don't mind having a go. Hi, I'm Steve Pavis. Just a bit of background. I run the National Safe Haven, work for National Services Scotland, and we work with a lot of NHS data, so I bring an understanding of the NHS data scientists. All of the presentations fantastic, and all really interesting projects, so we'll get into some questions, but I just want to premise it with they're fantastic. It's a great opportunity. The Canon one, I was interested in the concept that humans can't agree actually on the diagnosis. So there's an error rate. So you're kind of looking at these images. And yet at the same time, we heard that the computers need to know what the ground truth is to then be able to approximate it. And just for my own education, really, I'd like to know how those 2 processes stand together. So if we can't agree on the movement from the images of the human, but we're going to teach a computer to do it, how do we start to address those issues?
You both want to do it. Why don't you start
Okay,
and then pass the mic back?
So that's. Okay, so that's a really good question. So thank you. So you're absolutely right. If we tried to do it exactly the same way the human was, then we're going to risk training a system with uncertain data. There have been interesting papers that have shown that if you have enough data to train your system on, that kind of comes out in the wash. But we know that in this project we're not going to have that much data. So what we're looking at is doing a measurement which we think we can do more robustly as an indirect way of getting the RECIST. So although I didn't mention it in there, our first task is going to be to segment the tumour. So our ground truth will be the segmentations for the tumour, not these RECIST scores. And then given that we can generate the segmentation, then we can calculate the RECIST scores from that. So the ground truth that goes in won't be the RECIST scores, it will be segmented tumour.
Makes sense.
Which we believe we can do more reliably.
Has he answered that, or do you want to add?
In addition to that, there are other differences. So basically, when we are doing machine learning approaches, we can spend way more time looking at the particular data set. So it doesn't reflect the actual use case. So for example, when a doctor is presented with an image and they need to make that decision quite quickly, whereas in our case, we can afford to spend a bit more time, and we can also involve more than one person in making the judgment as to what the measurement is. So that's how these risks are mitigated.
Any more from the panel? Dave, would you like to answer something?
Maybe I can. Thank you. So I'm not sure how. Hold it there. Oh, gosh, I'm not used.
That one.
Oh, that'd be even better. Well, I like that one. I like this one. This is
we have all the technology.
So I think this maybe applies to more than one. We've got at least two that have got machine learning involved, and so a generic question for both either is really, do you feel that you've got enough? This is a bit basic, but do you feel you've got enough data to actually get the results that you want, or is there a kind of obstacle there that you foresee? How does this actually link into the?
So again, that's a very crucial question, and one of the difficulties with using machine learning techniques is you have a kind of dead spot where until you get enough data, you get nothing. Clearly, we don't know exactly how much data we're going to need to train the system yet. We just hope that we will have enough.
Yeah, and I think there's a bit of a difference. Well, at least in my naive kind of view of this, there's a bit of a difference between the first one and the third one. There if I can just call, yes, because for you, it's volume, but you know what you're looking for.
Exactly.
And for you don't know what the features are it's necessarily. So actually, for the maybe.
They want the whole history of SMR1.
The thing is, this is where we got, yes, that's right.
Yeah. So actually, to follow up that one, I don't know what the role would be for you have this because you're basically presenting evidence that a doctor would or somebody who is qualified would then use. I don't know how that fits in, because you could imagine having something that used fewer features, but in some way was indicative. It wouldn't have to necessarily give the answer.
Yes, that's right. So I suppose, number one, we wouldn't need to keep all of the features. That's one of the strengths of this approach, is that it allows us to feed in a whole bunch of features and then keep what works and drop what doesn't. Mm-hmm. So that's useful. And I guess, we don't have to present the right answer. We can just present what is a directionally smart answer. Don't know if that answers your question.
No, we're just exploring. People like Peter who probably know more about exactly how you do this than I do. So it's maybe for later.
Other comments from the panel? Or questions?
I just wanted to say that from the clinical point of view, I think all three projects are highly credible, and if they deliver what you are aspiring to deliver, then I think it's very important that there is definitely a clinical context to see the use of this. And this is partly the approach we had in the Innovation Challenge. It'd be very easy to go out with the healthcare sector to get technological solutions, which we instinctively or we actually know do exist. But there's no point in having something that doesn't have clinical applicability, and that's why it's so important to be working with your health service partners. I have some questions for Project 3 in particular in relation to that. But going back to the original one, I think this, certainly from the clinical point of view, is something which you can see easily the merit of it all. And I can, although you're taking a very niche clinical scenario, the potential applicability to this, if you can crack this, this would be very, very widespread indeed.
Well, we're starting with a hard case.
Yeah.
Possibly unwisely.
Kevin's got a comment.
It was really just a comment to the selection of a hard case. So there's two reasons I would argue that selection of a hard case, the selection makes some sense. One is if you can prove it in a hard case, you can prove it, you can roll it out to more easily segmented cancers. The other is that one could maybe access a larger library of data and pull radiology reports from NHS routine reporting, and arguably you'd have more data. But what you wouldn't have is you wouldn't have the robust RECIST scores. You would be falling down in the weakness of having variability of RECIST reporting, and so we've chosen, for better or for worse, to choose a more defined data set, but it's the ground truth is more robust. It's a more solid gold standard of RECIST scores.
I just had a quick question though. What you were saying in your presentation, Kevin, was the fact that the whole RESIST, this current project, is being primed by PRISM and any other algorithm you can get into it. What's the timescale for that? Where is PRISM? Are the two timescales going to actually be reconciled?
So PRISM has been open for about a year. So we are at the point of essentially collecting the image. There's kind of parallel pipelines in PRISM where we've got the tissue coming in, DNA extraction, genomic data getting analysed. We've got the same happening with the imaging data. The imaging data will come quicker. And we've actually got cases ready to be reported. And we've held back the start gun on that reporting so that we can slightly adjust how the radiologists report the data so that we've got what the guys call ground truth, robust ground truth in the DICOM images, so that we can, for the Canon, for the CIC project, we've actually got the best possible ground truth available.
Okay.
I really liked your kind of closing remark that it's about exploiting computers for what they're good at to aid clinicians and what they're good at. And I thought that was a really nice remark, and it relates to a lot of what these projects are about. But also it's interesting in thinking, as computers are able to do more and more, that's sort of an area to continually reflect on. As we're thinking of what computers are good at and what role they may increasingly take on. Does that change over time, and where is sort of the boundary in this? But that's something to kind of continually be reflecting on and thinking about the role of data and what it enables computers to do. That's a really nice remark.
Any other comments from the panel or questions? I mean, one of the things you spoke about was, I think, that it is a 3-month proof of concept, so you're trying to focus on, achieving it. And of course, what you'll also be thinking about, I'm sure, if you don't deliver everything, you're talking about the challenge, what are the measures of success that you're going to demonstrate that there's a technology that's viable to take to phase 2? And I'm sure you're all thinking about that, but that's clearly one for discussion with your stakeholders. What are the various measures that would show the progress in this phase 1 programme? Yeah. Any questions about or comments about JX?
Tommy Watchorn, National Services Scotland, Head of Innovation. It's great what you're planning to do, but it made me think there's probably lots of homegrown solutions out there already to bits of what you're trying to do, and how you might learn from that, how you might engage with that wider community on seeing what's already out there, so you can get an aligned solution that delivers everyone's needs rather than something new that people might not want to adopt at a later stage.
This is why in phase 1 we sort of already started engagement with a number of stakeholders around Scotland, and it's from sort of clinical as well as regulatory and also patients groups, to make sure that we involve as many stakeholders from different areas as possible to help us on the solution and to make sure that we are actually not duplicating the work, but we are working in sync with what's already there, and we just help to glue all these together to actually drive innovation, drive real-world evidence insights from the data that is already existing.
I think there's a comment from Aileen. You want to follow up, Aileen?
Thanks. Yes, it's a direct follow-on. Obviously, this is an ambitious project looking at integrating many data sources. Well, I notice you're also planning to try and incorporate patient-reported data. And given that the other strand of the challenge is around PROMs and PREMs, I wondered if you'd thought about potential duplication in that area if you add that to your project.
That's a really good question. So is your question really, there are existing PROMs and PREMs that are being collected, correct?
There are projects.
With PROMs and PREMs. So the idea is not to duplicate the PROMs that are currently being collected. So if you look at ICHOM, for example, the International Consortium of Harmonization of Outcomes Measurement, they have PROMs in over 81 different diseases. Many of those are being collected around the world. So the idea would be that the platform would allow the collection of existing validated instruments. It's not that we're going to create brand new content, but to make sure that there is a mechanism to tie in data that's coming in from patients with data that's coming in from clinicians and researchers, and ultimately being able to integrate it with existing data sources such as the electronic health record. Does that answer your question?
Well, it's a fine ambition, and ultimately that's where we all want to get to. But I just wonder if what you're biting off in phase 1 might be a bit too challenging.
Yeah, so that's not part of phase 1. So that's phase 1 is, that was the aspirational picture, and then there's the realistic picture.
So I guess we're going to have some discussion on all of the projects around what's delivered in phase 1 and what's making sure there aren't any roadblocks to extension potentially in phase 2. And that's what we're speaking about here.
Thanks. I was interested, you were the only project that talked about the use of the cloud for storing the data and also talked about role-based access to accessing that data. I wondered how far forward you are with those discussions. I know in England there's been a recent paper from Department of Health which essentially says, yes, you can go ahead and use the cloud, but the risk rests with the trust that decides to do that. In Scotland, I don't know of guidance to that effect, so I wondered where you were with Lothian in terms of moving data to the cloud.
To get the best information, to get the best input from various sources, we need to make sure the information is available. I mean, it can be hosted on the trust level or within the data centres within the NHS. There's no reason why we can't do that. It's purely currently that's what we've done at the moment. It's there, and GDPR basically says if you host it in Europe, it's acceptable. So for UK data.
Yeah, I'm sure that that's true, but the reality is that in Scotland there isn't any patient identifiable data on the cloud, so you would be setting a precedent. I just think you might be making your project more difficult than it needs to be by adding that element.
It will be also the part of the phase 1 and feasibility study to actually establish what is the best approach to this. So currently we are thinking ideally, if it could be put on the cloud, that would make things easier and more accessible. However, this is what we will be focusing on as well in phase 1, to actually check what's feasible and what's possible, and then decide the way forward for phase 2. Based on
and I guess there's talk about technicality, and there's also talk about patient engagement. And if you're young, you see opportunity in the cloud. I know my mum sees threat and security issues in the cloud, so I think that's an interesting area as well.
I've just only got one other comment to add, and at last week's joint strategy board of the Innovative Healthcare Delivery Programme, I was giving a follow-up of where we were with the Cancer Data Challenge, and I talked about the 3 companies that had been put forward for phase 1, and I bring with you a comment that is from that joint strategy board, say specifically with the CIC project, they felt this was highly aspirational, and if you managed to pull off everything that you were going to aspire to deliver, it would be really good. But the key to what your presentation attracted us was your access to legacy systems. Much of the data that we want to mine is held on legacy systems. So we're very, very interested in your ability to capture that onto this platform. It's just a comment.
We've got a vast experience on the integration and working with legacy systems in the NHS, so we are hoping to be able to achieve a lot. And we are also using some of the proven components just to make sure that when it comes, for instance, to data security, then rather than sort of building something from scratch, that, as you can imagine, can be very time-consuming and also quite expensive, we are using an expert partners, Pulse InfoFrame, to actually help us with those components of the system to be able to achieve as much as possible. But again, the phase one, the feasibility study, will show us exactly what's possible within the competition, and then we'll take it from there. But we would like to engage as many stakeholders as possible, and would like to work on links with as many data and legacy systems as possible as well.
Can I just make one add-on comment? Because the question about using legacy systems and bringing in existing data is not just about bringing it into a data lake. I think one of the things that was actually presented is mapping it to a global data standard. So if you're not mapped to a standard, the analytics, the machine learning, all of the other things that people want to be able to do become far more complex. And so I think that's a critical part of understanding, you know, in simple terms, you call something hypertension, I call it high blood pressure. We mean the same thing, but what's the common link? Yeah. And so, you know, I would just put that out there for everybody to really think about. It's not just the spaghetti of data, it's really organizing it in a way that it becomes usable.
Any more comments from the panel about JAX?
So one slightly nerdish question, because I just didn't get it from the talk. Because there's a kind of, when you're doing these kinds of things, there's a bit, you have choices to make about what you automate and what you don't. Because some of these things you could federate databases essentially by hand on the schemas and so on. Or you could do lots of automation to do to automate some of the mapping and so on. Where are you on that kind of spectrum? I'm not sure if I expressed that question very well, but the simple way of asking it is, how much fancy AI and machine learning and so on are you intending to use as part of the integration effort?
So I think there are two parts of integration. I'm not the nerdy one. You probably want to speak to somebody who is a lot nerdier than me. But from an interoperability perspective, I think JAGs have a lot of experience with being interoperable with EHRs, so pulling data either in HL7 or FHIR. But the second part of what you're really asking is the organization of data and essentially mapping it to OMOP or any other global data standard that are being used. Now, if you have experience in that area, it would be terrific to have a discussion with you. But currently, many of the efforts, other than SNOMED CT and SNOMED, have been manual efforts. As you know, the European framework and under FP6 and FP7 had a lot of resources thrown into Protégé and other systems. So again, the short answer is that it could be better, that there isn't a lot of automation currently, but that's something that obviously people are working on globally.
Yeah, and doing it manually isn't necessarily a bad way to do it. I mean, at the sort of schema level. So.
More comments about JX? Are we happy? Should we move on to Sharp Analytics then? Who wants to start?
Well, Sharp. Wow. Where do I start?
I'm hiding.
This work was built out of work you did with renal cancer patients. So tell me, you didn't mention that in your short presentation. I appreciate it was a short time. How are you? Who's your health board partner? How you want to share with the audience how you're actually going to engage the clinical community with this work?
So I can share bits. Unfortunately, my clinical partner isn't here today because he's struggling through a 12-hour shift in Kirkcaldy at the moment. So we're working with NHS Lothian on this one. The renal cell cancer, where that started from was during the hackathon. That was what we focused on, and the idea was it allowed us to specifically use all variables that were related to renal cancer. Now, we are still hoping to start focusing on renal cancer, and that will be our initial sort of test phase, will be to use that to try and understand. Now, that's because also our clinical partners have got expertise in renal cancer, and it's something that we've looked at before. However, we are trying to be a little pragmatic around the fact that maybe renal cancer is actually one of the most difficult ones to try and predict, and we don't know that. And so we are leaving ourselves, I suppose, the opportunity to say, if we try that and it doesn't work, we're not actually able to handle renal cancer, is there a different cancer that we're able to branch out into? So that's the idea, I suppose, behind, number one, where renal cancer started with and why we started there, but then also why we didn't mention it in that presentation. So we are still hoping to start there, but I can't guarantee that's where we'll finish.
I guess that brings in some interesting questions. I guess that brings in some interesting questions of when you decide that that isn't working and how you move on to another cancer. We have lots of people in the room, I'm sure, who can help with that discussion. Anyway.
Hi, I thought that was a fab presentation. I'm slightly concerned that ISD analysts are going to be running around in I'm a Data Munger t-shirt in the next few months. But just on I don't know if it's possible at all to do, but there's lots of interesting stories of people that exceed life expectancy. And have you got any plans to look at that kind of alternative data of what some individuals might do, alternative medicines, not as a research thing, but just, you know, to kind of look at outliers and if there is any trends that start to appear and those people that do go beyond where you would expect?
So certainly one of the things that we're really keen to do is have patients in this analysis and in this cohort who actually go on to live for a surprisingly long time, and possibly some that are still alive today, because that's part of the story. So they are legitimate data points, and so it's important that we include them, because otherwise we actually exclude that possibility from any predictions that we make. In terms of whether or not we will dive into those patients, probably not in the 3-month time period, but we will certainly include them as part of the analysis, because that's one path that a patient can go down.
Can I ask a question of the active clinicians, because I'm no longer an active clinician, I don't see patients anymore. How useful is this? You know, those of us who were clinicians are in no way surprised that that paper said that we were out by a factor of 500%. No, you know, I recognise that as a junior doctor 30 odd years ago, that there are factors of which we are unaware that are patient-related factors that are independent of the cancer-related factors. And that's the challenge and the glory of looking after patients, because they don't follow predictive paths. So going back to my initial theme that I was banging the drum, this has got to be clinically applicable. We do get faced with this question about what's my prognosis, and it's also about, we're keen to get clinicians to have these discussions so that patients have choices about how they choose to spend whatever time they've got, but it is not an exact science. So to the clinicians in the room, how applicable do you see this? You know, in theory, yes, it is applicable, and we would want to know how to do it, but how are we actually going to use it in practice? I'm not going to pick out Peter Hall, who's sitting in front of me, or James Mander, who's on the other side, but, you know, feel free to join in.
Thanks for not picking them out, that's really good.
This is a patient speaking.
Hello.
Heather.
My name's Heather Goodair. I'm a 31-year survivor of breast cancer. Now, I did not have a good prognosis. I should not be here now. But I think I'm here because I went to the Bristol Cancer Help Centre and learnt a great deal about how to improve my life in various ways, diet, mental attitude, etc., etc. But the point is, in those days, you weren't even told you had cancer. A lot of people weren't. You know, they talked about naughty cells, you know. And I certainly was not given the opportunity for informed consent for my radiotherapy. And that's not the only thing I'm suffering from now, but one of the things that really, bugs me now is the late effects of radiotherapy, which unfortunately are progressive. But I think in those days, if I'd been told, according to the Nottingham Prognostic Index, well, you might live 5 years, but probably not, I don't think that would have helped, actually. I think a question does arise about what you tell patients. And I know that quite a lot of patients don't actually want to know their prognosis. So, it's a very tricky subject. And I think one needs to say to patients, well, what would you like to know about your prognosis? But some people won't actually want to know. I don't know whether you've found that yourself.
Well, I entirely agree. And it's not an exact science. So it's the fact that some people will want to know it. But, I think increasingly there are cohorts of clinicians who feel we want to, where patients do want to have a say in what they do. If people have got less than a year to live, do they want to spend that year going up and down to a cancer centre, or do they want to do other things? So my question is, I think we do need to have this sort of information. I think it would be good to use the information we've got to try and teach ourselves and learn more about it. But I go back to the clinicians in this room and say, how would you use this? Peter.
There's a challenge. I'll pass the microphone over.
So I think, as usual, the patient in the room hits the nail on the head. There are a wealth of published risk models in renal cancer in the scientific literature, but the challenge we've always faced is in validating those and translating them into the clinic for clinical decision making. So I suppose the question, going back to the companies, is how will you overcome that hurdle after developing a new algorithm?
I think James and Kevin as well.
Yeah, I hope I'm allowed to comment. This is meant to be constructive. I know I'm a competitor, but so we've kind of done some work looking at trying to predict prognosis in mesothelioma, and we've done what many people have done is that we've looked at, and this is what you might do, is you look at the routinely available data because it's there. So blood tests, height and weight, tumour type, some basic, the stuff you can get your hands on. And so we built a kind of computational model to try and predict prognosis, and we're able to determine that actually those models are just not able to precisely predict survival because the biological factors that maybe determine a patient's outcome, like genomics or like tumour volume or like biology that's just not described in the blood tests or the admission data, just don't do the job. And so I think a constructive comment I would try to make is that to try and to make it clinically useful, those prognostic tools, you've got to try and select the richest biological data that you can get your hands on, which might not be the easiest data to get your hands on.
James is wanting to comment.
James Mander, Scan Clinical Lead. I think there are lots of different areas of medicine other than just the patient who might want to have useful prognostic information. And I think in this area of realistic medicine, I think it's of importance that we do try and pursue this route, but I acknowledge what's just been said. I think there will be enormous challenges, and I think there's a lot of data out there. A lot of it's in the managed clinical network audit teams. A lot of it's in pathological databases that will be quite difficult to access from individual health boards, I suspect.
Any other comments?
That wasn't meant to completely demoralise you. As you've come from Sweden and you're alone and your clinical colleague's not here.
I mean, it seems there's a theme in there about statistical robustness of the number and then what you do with the number. And what you're talking about is trying to get statistical robustness in the number as a first step, I guess, is what you're...
Yes, that's first stage.
Yeah.
Can I just make a quick comment about what's been said? I mean, I think what people are really talking about is decision support systems, which is very different to a decision aid. right? So when you're using data to help a patient make a decision about what treatment to choose, that really is not just on the basis of deterministic data, but on the observational real-world evidence, which is really a different data set from decision support, where you're looking at systems that are automated within the computer to be able to do that. So it was just a comment that I wanted to make, that we differentiate the uses of data. And the second comment, and maybe for feedback, is we're focusing a lot on big data because that's really the data that's currently available in the systems where we collect data. But we all know that a lot of data that is really meaningful is often unstructured and what we call little data, or in dictated notes, etc. And I'd like to hear from the panel, actually, how do you deal with that? Because if you look at some of the work that's being done in correlations, it's really on the basis of big data. But how do we deal with that piece that's really critical, that's unstructured?
There's a rush to answer that one from the panel.
I think it's interesting you've asked that. Well, the clinicians will not be able to give you that answer. They look to, I think I have to say, it was Dave who used the term nerdy, not me. We are looking to the experts to to do presumably NLP or something like that to try and tap into the unstructured data. But I completely agree, the wealth of information that's sitting there.
Yeah, so maybe I can say something not that nerdy actually about it. So I think a lot of this is getting sufficiently mature that there's a community of people around this. So in the UK, there's a network of people who are focused on text analytics for healthcare data. It's the Heal Text network. It runs out of Manchester, actually. So it's possible to join it, and it's possible to share expertise. And I think that's a good sign of maturity in the community. Personally, I think it'd be a very long time before there's some specific individual system that just kind of cleans up and does all the natural language analysis that you want on textual data. I think it's pretty hard to imagine, just because so many things, it's quite difficult once you get into pathology reports and all of this, just to disambiguate. It's amazing what you can do, and I think a lot of the stuff that I've personally seen in my limited experience has been ones where there's a kind of stack. So there's some commodity in named entity recognition, text analytics type thing that's doing the basic heavy lifting of the extraction. And then there's some other stage, or maybe more stages, where you're cleaning up that data. People are getting very good at being able to connect those two things together. So for years, for 20 years, maybe more, we've known that kind of machine learning algorithms just applied on their own tend to not give you, in many domains, the sort of performance that you actually really need. But when you combine that with ontologies, you give it a little bit of background information, then it starts to improve and you're on to something. So I think it's quite interesting to look at these kind of integrated systems, and a bit skeptical of things that aren't integrated in that way, I must say. I mean, while I'm on, I mean, the other thing that I'm a bit skeptical over, things where it's just kind of turnkey systems and it gives you the answer back. So I think for a lot of these things, there's actually, because for a lot of them in the end, you are looking at the evidence base and you want it structured somehow. You don't want just to be told, this is the answer from the unstructured data that we acquired. You do have to have the traceability. And not many people think about building those into their systems. But it's beginning, and the good news is there is a community in the UK specifically looking at this.
A couple of comments from me on this one. Firstly, I thought the choice of data sets might be a little bit limited, particularly if you want to look at comorbidity, as you said in the third one. The 01 data set is about people that have been admitted to hospital, so they must have had a condition that was sufficient to take them into hospital, and I wondered whether you'd considered looking at prescribing databases. My colleagues from NSS will kill me on this one because that's a massive amount of data and difficult to use, but yeah, and they're giving me daggers now. But in terms of statistical predictability, that's probably important. My other thought was when you put up your stakeholders, there was one rather frightening set of stakeholders that you didn't mention, and that's the insurance industry. And I was thinking, if you could genuinely do this, what would the pension companies and the insurance companies do to know about longevity and predictability? And where do you stand ethically in terms of releasing that information to those kind of companies?
So,
just a quickie question before lunch.
Just before lunch, yes, I saw that one out.
Firstly,
wish you hadn't come for it.
thank you for the suggestion on data set. That's exactly the sort of thing that we're here to hear about and learn about. Apologies to your colleagues. In terms of the insurance industry and the ethical side of things, I guess that's where we talk to patients and patient groups and that side of things. Inherently, it sounds pretty dodgy and sounds like the sort of thing that you shouldn't use public health data to do, but I'm not an expert on that. All I can say is it sounds a bit dodgy.
But surely you will need to make a decision the first time they come knocking, Standard Life come knocking, say, could I have that algorithm, please, because it'll help me to work out my premiums. I'm not saying it's negative, I'm just saying it needs to be thought about. If premiums are priced better, perhaps that's a good thing. No?
Yeah, I think that's one where we would engage with the various patient groups and that side of things. But yes, good point.
I pick up since some patient engagements coming up. Well, I really liked your presentation. I thought it was a really nice overview of the process and also of the various stages where you're making decisions and judgments. And I think that's where it highlights the importance of patient engagement or wider citizen engagement. That those are points where there's real value in engaging quite broadly. So in the list of where you had what was definitely interesting, maybe interesting, I've done it the wrong way around, probably interesting, maybe interesting. And at that stage, those are really things where patients and wider publics can have a real useful voice in offering things that maybe are interesting, that might add insights that we wouldn't otherwise think of or wouldn't otherwise include. And then there's wider kind of ethical considerations around what do you do when the insurance companies come knocking. These are really diverse sets of considerations where public engagement, citizen engagement can offer really useful insights and useful potential solutions to challenging problems.
So specifically on the point of, I guess, the feature generation and the idea that patient groups would have a view of, look, this is an important feature. That's one of the things with data science whereby they say that to be a good data scientist, you've got to get really close to the domain because otherwise you can't come up with things like that. You can't understand what's going to be important to feed in. And so that's a great use of patient engagement at this point to really get close to the subject matter.
Okay, we're running slightly late, but it's been a really important, I think, feedback, and I think thank you very much for the three, for your excellent presentations. I think we can see the ambition and the challenge in each of the three of them, as I've said. Hopefully that's been useful feedback to you for starters. You can continue over main course over lunch, and there'll be the round table afterwards where you can talk to people as well. But if I can ask you to join me in thanking the panel for their
Okay, thank you everybody. Hello, my name is Dave Fitch. I'm Head of Operations at the Data Lab, and I am the Programme Executive for the Cancer Challenge. First of all, I'd like to say thank you to everybody for everything they've done today. Everybody for coming along, for the companies, for everyone who's participated in the discussions. I mean, I've found it really useful. I hope the companies have found it really useful. And I'd like to give a big shout out to two people in particular. One to Steph, who's done everything to get to this point. And the other to John, actually, John from Innovate UK, who actually did an awful lot of the heavy lifting right at the beginning to prove to us that actually, yeah, this was doable. So he deserves a huge amount of credit. So. Now, I believe the point of this session is for the companies to kind of reflect on what's probably been a long couple of hours, and hopefully quite intense and quite useful, to tell us a bit more about what they've thought, what they've learned based on today, and do some reflections and ask us for any more help and support. So, Dominic?
Sure, yeah. I mean, in no particular order, I've got a list here. I'm hoping you guys will chip in as well. First of all, again, thanks very much for a fabulous day, really interesting and helpful. A lot of good input to our project. So, yeah, I mean, in no particular order, one thing that possibly was new and certainly we need to take account of was the issue of patient engagement and that it's never too early to start with that. So I think we're going to certainly have some conversations about what that actually means over the next 3 months. There was a lot of discussion about do we have enough data or indeed do we have any data. And the answer is yes, we do potentially have data. However, that's all subject to contractual completion. And in that respect, there were also questions about the project timescales and how we felt about a 3-month trial and the need for our milestones or deliverables to be pragmatic and achievable. And certainly, I think I'll be revisiting the milestones that we put into our contract and looking at how we can possibly achieve those. And we'll be doing our level best with that. But certainly, that was an interesting reflection. What else have we here? And there was some interest. People were checking whether the quality or the nature of our data was suitably generalizable, and I think we were able to make the point that we're fortunate in that the PRISM study is a multi-site trial, so that's going to be bringing in data from different locations around the UK, including different scanner types and, to some extent, different scanner protocols, so we're hopeful that that will be helpful. There was an interesting suggestion about whether in some way through co-locating Dr. Blythe's site in Glasgow, whether we might be able to get some initial work done even prior to the signing of contracts. I'm not really sure whether that's possible or not, but we're fortunate in having a new office at the Imaging Centre of Excellence at Glasgow University, so there's potential for us to do something there. And then there was a fair amount of discussion about how, given that mesothelioma is a relatively special case, how generalizable our outputs would be. Well, one response to that was that even if mesothelioma is a special case, it's still a significant case, and there are real people who could benefit from the results, regardless of how generalizable that can be. And in a sense, I think we're in agreement that an algorithm that we train for mesothelioma will not be immediately transferable to other cancers. But it will be a proving ground of a process. Much of the process and some of the software deliverables are reusable, but in practice, these kind of projects require specific data with specific ground truth for a specific cancer, and that's in a way a handle that has to be turned multiple times until enough algorithms of that kind cover the ground.
Yeah, I agree.
Do you want to add anything else?
No, carry on.
I think I might be done. Finally, there's one question about if there's so much inter-observer variability in what humans do, how can we trust, or what's the benefit of trying to get a computer to reach a conclusion? And I guess what we're saying there is that the fact that the data sets we have are red and triplicate is a good enough target or generalization to be aiming for. That's me, I'm done.
Yep.
You guys?
That's good.
I think the other three have got to say something.
I
think Dominic's done his bit. So.
I think we all contributed to that by being there.
I was going to say, spot the manager at the table. In terms of the three discussion groups, what was the bit of advice that you got which you think is going to be perhaps most helpful to you over the next couple of months?
I think the pragmatism, and in fact you made the point clearest of any of the places we went, that we have to be realistic in what you can achieve in 3 months where stuff is outside of your control, and access to data and things is reliant on getting processes through which we know can be slow. Anyone who's worked on a research study knows that going through ethics and getting data agreements in place can take a lot longer than anybody thinks at the outset. And so that is obviously a risk. And I made a flippant comment at the time that we would be twiddling our thumbs while we wait for the data. And to a certain degree, that is true. For a data-driven technique, you need data.
Just blithely ignoring all the work that I'll be doing getting contracts signed.
All the work with the contracts, yeah. And so you can see our different perspectives on a project, which is why you should have a balanced team working on a project and not just scientists like myself.
Okay. Has anyone got any last kind of thoughts or comments for Canon at this point, aside from good luck, Godspeed, and all of that?
It's going to be fun. We're looking forward to it.
No, I think the thing is, I think for all three projects is, you know, both individually for the companies and I think for the wider healthcare ecosystem, we're all going to learn a lot, and I think that's really going to be valuable. So I think we're all really looking forward just to seeing what comes out. So last chance for embarrassing questions, non-embarrassing questions. Okay, thank you very much, Canon.
Thank you very much for all your feedback today. It was extremely valuable, and we will try to incorporate as much as possible in a short feasibility study of 3 months, and then hopefully in phase 2. We received a lot of advice, a lot of feedback, and also a lot of information around the subject of our project, and also around hematology and what hematologists and other clinicians are facing and struggling with at this stage in terms of data and access to data. I listed 3 key points that we are going to take from today, among other feedback we received. And the first one is around focus on consolidation of dispersed data from number of systems that clinicians are using on a daily basis, and also on the sort of underlying systems that other systems can feed into. And then focus on wide stakeholder engagement and scalability of the solution to make sure that we are not going to deliver another silo system that can be used by just a few, but focus on things that can be delivered for the benefit of most. And also on looking at turning passive data, which currently sits in a number of systems, including EPRs, into dynamic real-time data that can be used in a meaningful way by clinicians, patients, and policymakers, and also to look realistically as to what can be achieved within 3 months and 6 months this project is going to run through. Anything else?
Just a real quick comment, which was, underneath it all, I had the feeling that everyone that was giving us advice really wanted it to succeed. Yeah. They understood the size of the challenge, they understood that it wouldn't be easy, but everyone was trying to give us little nudges in the right direction so that we understood what we had to do to optimize our chance for succeeding. Because of course, if we do, you win, because you get what you want. So hopefully that same win-win attitude will progress as we do our work, and we can work through all the hurdles together.
And I think just from our side, on behalf of JX, I think what we've heard today has been exceptionally exciting. The stakeholder engagement has been phenomenal. And we're really excited to be part of the CIC. It's very inspirational. I know we put a very aspirational project forward. As Mel said, we've got 3 months. But you know, the overall picture that we do want to put forward, yes, is aspirational, and we can do it. But the 3 months will be very, very interesting and challenging. And thank you for all your feedback. As Mel said, it's been really invaluable, absolutely. So thank you.
So just one additional comment, because even though we're picking a disease site, which is hematology, some of the comments from the clinicians were, you know, hematology is a small segment of the population. So as we look at how we're going to scale this, we're also going to be talking to other disease groups so that we understand what other disease groups are working in. So whether it's oncology, et cetera, that was some of the advice that came back to us that said, look, for this to be scalable and useful for the entire country, it can't just focus on a subsegment. So thank you for that feedback too.
Okay, thank you. Anybody got any further bits of advice, comments for JX? Everyone's lost their tongues. Or everyone's trying to think, what was in the shortbread? There was some flavouring in the shortbread. What was it? That's what I'm sure. That's what everyone's actually really thinking. Was what.
And is there any more left?
Yeah.
I believe there's a little bit left. If there's no other comments or anything, I'd say hey, thank you very much and good luck with the next few months.
Thank you.
My key takeaway, what have I enjoyed? It's been it's really interesting, very overwhelming, lots of advice, lots of feedback, lots of questions, lots to think about. It's been cool seeing what the other companies are doing as well, actually. That's quite cool. I like that. In terms of what I've learned and what I think we'll have to do differently, a key piece for me is around the data access side of things. So getting a temporary contract, what we need to talk about in order to prove that this is of public benefit and will help people to enable us to get the data that we need. Also how to narrow down the scope if we need to only focus on data that is we can demonstrably say, look, we definitely need this data. There's a piece around, I suppose, literature review. So there are models at the moment that try to do bits of this over different data sets, over different sizes of data. That's a really interesting area that we absolutely need to look into, read into, and understand what the state of the art at the moment is in various different areas. What else? I like the idea of patient outreach informing the variables that we actually pick to go into the model. I think that's a clever and neat idea. The idea that the people who are going to be most able to say what variables are likely to influence are the people who have cancer and who are aware that actually this is making me feel terrible versus actually this one doesn't seem to have that much of an impact. I think that's, yeah, those are all things that I think we'll take away with us from this. I just take all of the good ones.
Yeah, I mean, you'll know me as the person who sat quietly and took notes, so that was my main role.
And I must say, some of the neatest notes I've ever seen. And if any of you have ever seen my handwriting, I'm extraordinarily impressed. So was it worth coming from Stockholm? Good.
Absolutely, yeah, we've made some excellent contacts and very nice to put faces to names. For me especially, I've not met any of these people before, which has been very valuable and enjoyable, so thank you to everybody for that.
So has anyone got any last bits of advice for Sharp Analytics? Once again, everyone's still thinking.
For what it's worth, do feel free to come up to us afterwards. If you do, but you're shy.
Yes. I think at this point, we'll wrap the formal bit of proceedings up. I still think there's a bit of shortbread and tea and coffee, etc. outside, so people can still have a bit of an informal chat if they'd like. Otherwise, I'd like to once again say thank you to everybody for coming and participating. I think the level of engagement from everyone here has been absolutely phenomenal. I'd really like to thank you for that, and just to wish everyone good luck in getting home tonight, particularly if you live on the West Coast or if you live in Pennycook. You know, the snow capital of Scotland, apparently. Okay.
Apparently it's now flooding in Glasgow after the snow, so, which is what the transport issues are. It'll still be snowy in Midlothian, though. So.
Okay, lovely. Thank you very much, everybody.